Good morning.
I'm Kim Margolin, co-organizer with Essner, co-organizer.
Thank everybody for being here. Thanks to our sponsors, St. John's Cancer Institute, St. John's Hospital, and the Borstein family who helped make this all happen. So we hope you will enjoy our day. We try to make it a reasonable length of time so that everybody can hopefully will stay throughout. Certainly ask questions if you have any along the way. And then just real quickly, we had to switch the order. So Dr. Lowe is going to go at 11:15 rather than second. So not sure if that matters to anybody except for Dr. Lowe. We had to fix things for him. So we're going to go ahead and get started. Kim's going to introduce our first speaker. So again, thanks for everybody being here today.
Yes, we do thank you. We thank the sponsors and everybody who agreed to speak. We think we've got the best speaker list ever and the best topics ever because we chose people and topics we thought would be very important and timely and of interest. So our first speaker is going to be Dr. Jonathan Zager, a.k.a. John. He says he's got some fancy titles, but he wouldn't tell them to me. So he's at Moffitt Cancer Center, which has an enormous and wonderful melanoma program. He's going to be our keynote speaker and speak about the approach to regionally advanced metastatic melanoma. And then I will be going after John.
Thank you for the kind introduction. And yes, in the next 45 minutes, my plan is to go over my approach to regionally advanced melanoma. And here are my disclosures. I'm going to try to get through in the next 45 minutes some discussion about neoadjuvant therapy, then go into perfusion-based therapies and intralesional therapies, which are our methods and modalities to treat regionally metastatic disease. So first, we're just going to touch on neoadjuvant therapy. Why do we do neoadjuvant therapy? What are our expected results? So as you probably know, neoadjuvant therapy is the administration of a systemic therapy or local regional therapy prior to surgery in patients who need to have accessible and accessible regionally advanced or metastatic disease. There is a plan after neoadjuvant therapy and not much data at all to tell us that we should not carry out resection of the tumor after a defined period of time. Postoperative adjuvant therapy could be plus or minus and may or may not be used, and we can use tumor response, amount of viable tumor to guide postoperative adjuvant therapy. There are many pros and cons of neoadjuvant therapy. The pro is that you have the tumor antigens present during the treatment. Treatment is given before any postoperative immune state. Cons, it does delay surgical intervention. There could be progression of disease, which leads to an unresectable situation, especially if there was a borderline resectable tumor. And full pathologic staging is not known at the time that the therapy is initiated. There have been several publications guiding in the international melanoma community and discussing neoadjuvant therapy and kind of trying to put together a bunch of guidelines. There have been several trials that look at neoadjuvant therapy, especially those involving nodal disease for metastatic melanoma. Some of these trials had de-escalation of surgery, but SWOG 1801, NADINA trials, which are very recent and obviously very big trials talking about neoadjuvant therapy in terms of regionally advanced nodal disease. These did not include de-escalation of surgery. So the surgery or completion lymph node dissection was still part of these clinical trials. But as we move forward as a melanoma community, we do have to take into account de-escalation of surgery and how do we de-escalate or avoid the morbidity of these large node dissections. And as you guys probably know, the SWOG 1801 was neoadjuvant versus adjuvant, plus adjuvant versus adjuvant alone, and there is a significantly improved event-free survival in the neoadjuvant group. The same thing goes with NADINA trial, except here it was a response-driven adjuvant therapy where adjuvant therapy was given based on the amount of viable tumor in the specimen. And again, we see a significant advantage in terms of event-free survival for the neoadjuvant group. I mean, these curves could just overlap. And with the curve to the right, as you can see that as you get a better pathological response, your recurrence-free survival is better and better as time goes on. Then comes the Prado trial. This preceded both Nadina and SWOG. And here we start to see a small trial where we de-escalate surgery and adjuvant therapy based on pathology response. So in these patients, just like SWOG and Nadina, if you took out the index lymph node. So the index lymph node was marked. It was identified prior to neoadjuvant therapy. You took out the index lymph node. If there was a path complete response, these patients avoided further therapy. They did not have the therapeutic or complete lymph node dissection. They did not have adjuvant therapy. So we're seeing now this de-escalation of surgery and adjuvant therapy, which is a huge benefit to the patient as long as it doesn't impact survival. And again, these plots, you can probably put these up against Nadina and SWOG. Every plot looks the same. The green is those patients with major pathologic response, and they do very well with just their index lymph node. So it definitely is a new standard of care for treatment for locally advanced, regional, and even limited metastatic disease. But we do have to think about surgery for residual disease. Some patients may not need an operation in the future, but we don't know that. There's no evidence to say that we shouldn't be doing surgery. So this is really a focus for research and discussion. For patients recurring after surgery, if they had a great response and depending on the time to recurrence, you might want to consider reintroducing the same therapy, especially if it worked before. And when we look at this graph from the Prado trial, you see radiographic response versus pathologic response. And it's important to note that not every radiographic responder or non-responder is equivalent to a pathologic responder. So here, the graph on the left, we see a 45% radiographic response after neoadjuvant therapy, but those patients actually had a 72% overall response in terms of looking at their index lymph nodes, major pathologic or near complete pathologic response. The question is, how do we find these metastases after we give neoadjuvant therapy? What if they disappear? What if we have an axillary lymph node and it was 4 centimeters before neoadjuvant therapy and now everything looks normal? Again, as I mentioned before, we still, at this point, need to go in and take these out. So we do have to have a way of finding the metastases if they disappear. And that's where fiduciary markers or clips come in. They do play a role in neoadjuvant therapy. We use them all the time at Moffitt. Especially in these patients where the lesions disappear. In particular, we use 2 different types of clips at Moffitt, the Smart Clip and the Savvy. I solely use the Savvy clip. This allows us to tag, let's say, an index lymph node for a lesion, and then come back after a period of time to find this lesion and take it out, especially if the lymph node reverts back to normal on imaging. There's no way, as a surgeon, I can go into the axilla, find a lymph node that is now normal compared to all the other nodes. So these markers can be placed at any time pre-surgery. They're inert. They can stay in there for months. Here you can see a marker placed inside a lymph node prior to neoadjuvant therapy. We took out the lymph node. I always do a specimen radiograph in the OR, so not only do I have the probe that allows me to identify that the marker is out, but I want belt and suspenders, so we take a picture and you can see these 2 radar-guided localization clips placed in the specimen. And we looked at our data not to discuss really how many patients responded after neoadjuvant therapy. I mean, there's a million reports about that and more trials and studies ongoing, but more so to look at, should we be doing these clips? Are they helpful? So in our first 23 patients, we're about 50, 60 patients now, 87% had a radiographic response. So you're talking about a lesion that might have been palpable, that definitely was visible on imaging, but now almost 90% of them had some sort of response in the index lesion. We are 100% successful in getting out the index lesion. And as I mentioned, these clips can stay in there forever. They're inert, so it's a median of almost 100 days before getting them out. The take-home message here is that 14 lesions of the 23 were palpable prior to neoadjuvant, and then only 5, almost about a third of them, remained palpable after neoadjuvant therapy. So 2/3 of them were non-palpable. That is why we do have to move in a direction and work very closely with our medical oncologists. If they're going to give neoadjuvant therapy and down the road refer them to the surgeon to take out that index lymph node, the index lymph nodes need to be placed at the time of biopsy or at the start of neoadjuvant therapy. So remember, 65% of the lesions in this small series become non-palpable. We're very successful at removing the lesions, and it's not very hard. It's like doing a sentinel lymph node biopsy. So if you have a high index of suspicion and you're going to biopsy the lesion, you can do a core biopsy of the lesion and place the clip at the same setting through your radiology, and then give neoadjuvant therapy. And this allows us as surgeons to come back and take that index lymph node out in the future. And future studies like MSLT3 with markers and tumor-bearing nodes or metastatic soft tissue lesions are in progress and should be opening, I'm hoping, either this year or early next year, where we're going to specifically look at this and, surgery, response-driven surgery and adjuvant therapy. Okay, so that's systemic therapy, but there are other ways to treat metastatic disease that don't involve systemic therapy. One is isolated limb infusion, or ILI. It's a way of minimally invasively inserting catheters into an extremity, arm, or leg with metastatic in-transit disease, tourniquet isolation. I use it for unresectable in-transit melanoma, sarcoma, or other cutaneous malignancies. It's based on melphalan chemotherapy we put into the extremity, and it's an alternative to the complex hyperthermic isolated limb perfusion that's rarely done in the U.S. anymore. So here's a picture of ILI. So what's needed for an ILI? You have a heating source to heat up the chemotherapy. Here you can see right here the catheters are placed. Usually there's a pneumatic tourniquet. It's probably hard to see from the back of the room, but this patient had a couple of in-transit metastases that were just slightly proximal or underneath where the pneumatic tourniquet would be placed. So instead I use an Esmark tourniquet, wrapped it around as tight as you can, clamp it to the table, and now this limb is isolated. There's some temperature probes. I monitor the pulse to make sure it disappears with isolation, because if you still have a pulse, then we don't have isolation. And then we heat up the chemo and we heat up the extremity and circulate chemotherapy for 30 minutes. Fix this. Hopefully I don't, all right, good, perfect. Well, I might need AV help again, or I can just use this. So we did look at our long-term efficacy of ILI. We combined our data with a lot of high volume centers across the world. We looked at 700 first-time isolated limb infusions for in-transit disease. Overall response rate was about 65%, complete response almost in a third of patient. The most important thing to notice here is that these complete responders have a great, very long-term overall survival, and as you can see, have very little toxicity. So not everybody with in-transit disease needs to have systemic therapy. We also can prognosticate with these patients. They can come to the clinic, they have a ton of lesions or they have a few lesions. How are they going to respond? So there's been several papers that look at burden of disease, and we know that low burden of disease, these patients do better with overall response rates almost in 3/4 of the patients, and almost half the patients have a complete response with low burden of disease versus just under 50% response and a quarter complete response with high burden. And that's defined as greater than 10 lesions versus less than 10 lesions, and in the low burden, no lesions greater than 2 centimeters. There is some toxicity of ILI, mild in most patients. This is just some swelling temporarily, some erythema, and maybe minor blistering in grade 3 disease, grade 3 toxicity. Grade 4 toxicity is seen in less than 5%. I would say it's probably less than 2% of patients, but in our studies, when we combine it with everybody, it's less than 5%, and that's compartment syndrome, where we do have to do a fasciotomy to relieve the pressure. I've done one compartment syndrome fasciotomy in an ILI patient in 20 years at Moffitt, so I would say that's probably less than 1%. And no grade 5 toxicity, which is tissue loss. The toxicity, the swelling and erythema does resolve in everyone by week 12. There's no systemic toxicity seen at all. And yeah, as I mentioned, I've only had one patient with grade 4 toxicity, and now it's way over 300 ILIs. So summary of ILI, not all in-transit metastases are going to develop distant metastatic disease. It's actually pretty common to progress in the limb rather than distantly, so do we really need to focus on systemic therapy right away? There is a 60 to 70% response rate. Obviously, burden of disease matters. If we can get the patients early before we give them systemic therapy, because that's not going to work in everyone, just like this doesn't work in everyone, we can even push it to a higher overall response rate and a higher complete response rate, and maybe spare some of these patients the need for any other therapies. And complete responders do have a long-term overall survival with a median greater than 7 years. If we look at immunotherapy trials, all the trials that led to our current approval of all of our great systemic therapy, immunotherapy drugs in almost 5,000 patients, we really cannot tease out if any of these patients had in-transit metastases that were treated on any of these trials. So we do base a lot of our data of giving systemic therapies for these patients with very little evidence to support that's the best thing. We tried to look at this as a group, again, with a bunch of other institutions that perform ILI and also local regional like TVEC. We compared immunotherapy, TVEC, and isolated limb infusion or perfusion. We had just over 550 patients. You can see the breakdown here. Median follow-up greater than 5 years. Tumor burden was associated with ILI and ILP used most often. So these patients are coming to us later with more advanced disease for ILI. Maybe other options are failed, or they just were not diagnosed soon enough. Tumor burden was lowest with TVEC. Breslow thickness was lowest in the TVEC patients, and TVEC was used earlier in stage 3B versus 3C disease. When we look at comparing the results for the patients using immune checkpoint inhibition as the reference category, TVEC had the highest odds of a complete response. Despite having the best initial response rates, ILI had the lowest or shortest progression-free survival in this. And then here you can see very simply in the overall progression-free survival, local progression-free survival, overall survival, and distant metastatic-free survival, TVEC, which is represented by the black line and ILI represented by the red line. Obviously, TVEC was very favorable in this series. So are we burning bridges? ILI or TVEC, in my opinion, does not burn any bridge for escalation of therapies. If it doesn't work, we're going to know in 6 to 12 weeks these therapies aren't working. We can pivot to immunotherapy or targeted therapy very easily. I have never heard of an ILI patient having thyroiditis, pituitary that's non-functioning, adrenal insufficiency, diabetes, or any of the other lifelong immunotherapy-mediated toxicities, all of which can significantly affect quality of life. So if we can do TVEC, ILI, or other regional type therapies for these patients, maybe we should start with that, select out the patients who are going to respond, remove the possibility of getting these lifelong toxicities, and pivot to systemic therapies in the patients who truly need it. However, if we go with immunotherapy first, we might see an increase of burden of disease, increase in stage, possible progression of disease beyond the cuff, and then these therapies, as you saw before, don't work as well. But it's not all or nothing. ILI, TVEC, they're not a thing of the past. We use them in a lot of patients. Other TVEC and oncolytic viruses are contraindicated in patients with immunosuppressants, so we won't be using it. And then immunotherapy might be contraindicated in certain patients. Basically, what do you do with the patient that has a BRAF wild-type tumor and has Crohn's disease or ulcerative colitis or really bad myasthenia or rheumatoid arthritis? So we do need these types of approaches for some patient population. We can use it in palliation for symptomatic limbs that are just speckled with in-transit metastases, and then maybe, just maybe, we can use combination or starting with a regional therapy and then going to systemic therapy if ILI fails, or combining the therapies. I don't know how to sequence them, but we certainly can select out some patients who are going to respond, and they will have long-term benefits from it. So TVEC, I just mentioned in that combination, in that comparison trial, TVEC is a herpes virus, an HSV1 attenuated herpes virus that we do use to inject into 3B, 3C for a metastatic disease. There was a phase 3 trial called the Optum trial that showed TVEC was significantly improved over GM-CSF in these patients. Here you can see the waterfall plot. However, when we look at the trial and we look at overall survival in all the groups that we put TVEC on versus systemic GM-CSF, yes, there's a clinical benefit here on this Kaplan-Meier plot, but the p-value was 0.051, so technically it was a failed trial, the Optum trial. However, we don't use TVEC for patients that have stage 4B, 4C disease. We really use it in the 3B, 3C, 4A disease, and here when we break it down into those patients versus the rest of the stage 4 population, we do see a significant survival advantage in this population. So those are the patients that we currently use it on. It does work. 64% of lesions in the Optum trial responded to TVEC. It has a bystander effect. Over a third of non-injected, non-visceral lesions also responded in the Optum trial, and even 15% of visceral lesions responded to locally injected TVEC. So it does have a bystander effect, and we do use it. We use it at Moffitt in patients that have failed systemic immunotherapy. Sometimes we take them off immunotherapy and use TVEC. We see an overall response rate of 45%. Sometimes we add TVEC to their single agent Nivo or Pembro that they're failing, and we do see about the same overall response rate. I'm going to show you a couple of patients. So again, this is, I think, an 80-year-old gentleman. This is your typical in-transit satellitosis. He had a contraindication to going on systemic therapy, and in 6 months, the TVEC completely cleared up his in-transit disease. This lady had 2 large in-transit lesions from a foot primary on the medial and lateral ankle, and all these in-transit lesions in the mid-medial thigh. These were so painful, she couldn't wear shorts, she had to wear a dress, nothing could touch them. So we injected TVEC to the medial and lateral ankles. We didn't touch any of these in-transit lesions. It should be noted that she failed immunotherapy. She failed a PV10 clinical Rose-Bengal clinical trial. She failed isolated limb infusion and then came to me for a TVEC injection. You can see after 3 injections, just 6 weeks, these are starting to flatten out, and all the lesions in her medial thigh are starting to go away. Now, after 3 months, we're just left with some eschar here, and we biopsied one of these grayed out in-transit nodules, and it turned out that that was a complete bystander response, and she had a CR of all her disease after about 3-4 months of TVEC. So TVEC is effective. It's safe. It has very few adverse events. Usually the patients have mild to moderate flu-like illnesses. The overall response rate's anywhere from 40 to 60%, depending on the stage, line of therapy, and burden of disease, and it can be used in IO failures, and we use it quite frequently at Moffitt. More recently, RP1 is another type of herpes virus, was combined with Nevo. I think Replimune is currently trying to figure out how to get this approved. In my opinion, it was a very impressive data. Here's their study design, but you can look, this is in the IO failed population. They had a 63% disease control rate and a 34 or so % overall response rate in patients that had failed systemic therapy and had injectable lesions. These are all stages of 3 and 4 disease. So they really are starting to run out of options. These patients might have options like TIL versus RP1 plus Nevo, but they're starting to run out of options. This combination looks like it's very effective, and I'm quite confident that the company will figure out a way to eventually get it on our shelves. Duration of response, the median duration of response is about 22 months here, and you can see, that's still impressive for the IO failure population. When we look at efficacy here, you can see just over a quarter of overall response rates in patients that had both anti-PD-1 and anti-CTLA-4. 36% in patients who had just primary resistance to single-agent monotherapy anti-PD-1. So it does work in that population. Obviously the combination of Nevo and RP1 is well tolerated, especially knowing that these herpes viruses are well tolerated, and these patients already have limited side effects from immunotherapy. Otherwise, they wouldn't be going on to more immunotherapy. And then lastly, this is basically my passion, percutaneous hepatic perfusion. We're going to switch gears for a second. So this is what we use with another type of melanoma, uveal melanoma, that spreads to the liver. Characteristically doesn't respond to systemic therapies, but this is a very bad problem. These patients, about 50% of patients with uveal melanoma are going to develop metastatic disease. 95% of the cases, the disease is in the liver or solely or liver predominant. And historically, the median survival after diagnosis of metastatic disease in the liver for these patients is less than 12 months. Percutaneous hepatic perfusion was FDA approved in August of 2023. It's a way, just like isolated limb infusion, of minimally invasively putting in catheters, isolating the liver with a series of catheters and balloons. Balloons are above and below the hepatic veins. We isolate the liver. We perfuse the liver with high-dose chemotherapy. This double balloon catheter, I'm going to show you some more pictures in a second, is able to collect the effluent that is coming in from the hepatic veins. So the hepatic artery catheter puts in the chemotherapy, circulates in the liver, comes out the hepatic veins, collects between the balloons, actively pumped out with a cardiac bypass machine, filtered extracorporeally outside the patient. Through cardiac bypass, veno bypass, the filtered chemotherapy, the filtered blood without the chemotherapy is then reintroduced in a third catheter into the internal jugular. So here you can see that cartoon again. The double balloon catheters are blown up. The liver is being saturated. The blood's coming out with chemo. It's being filtered extracorporeally, reintroduced into the patient. This is sounds very complicated. It's not as complicated as it sounds. These patients come in the same day, they leave the next day, and they go home. They have up to 6 percutaneous hepatic perfusions, depending on if they're doing well and tolerating the procedure and responding, obviously. Access in our institution is by interventional radiology. They map out the celiac access. You can see here the splenic artery, the gastroduodenal artery, right and left hepatic arteries. We park the catheter right here, or we individually catheterize the left and right hepatic arteries and then perfuse the liver with high-dose melphalan, again, for 30 minutes. How do we know that the melphalan's not leaking around the patient, into the patient and getting systemically? Well, here you can see a little cartoon where we have isolated the liver with the balloons above and below. I turn off the pump and I do a retrograde IVC venogram, which you can see lights up the vena cava and the hepatic veins. There's no contrast leaking around either balloon. Now we go back on pump, open up the filters, and it's good to go in terms of giving this patient chemotherapy. We know we have good isolation. So instead of tourniquet on the limb, this is balloon isolation of the liver. It started out as a randomized trial, the FOCUS trial versus best alternative care. Due to patient reluctance to go on best alternative care arms and flying to Europe where this was CE mark approved and spending their life savings on PHP, we went back to the FDA and asked them if they would be okay with a single arm trial, which they agreed to. These patients get PHPs, percutaneous hepatic perfusions, every 6 to 8 weeks. Patients with progression in the liver or extrahepatic came off study. They were scanned every 12 weeks. Here's the randomized portion of the trial to best alternative care at the time. So this was TACE, Pembro, IPI, or tacarbazine for these patients. When we look at the randomized portion of the trial, PHP versus best alternative care, here you can see about a 36% overall response rate in favor of PHP versus 12%, so that's a tripling of the response rate. Disease control rate was doubled, 73% versus 37%, so a doubling of disease control rate in these patients. Progression-free survival, a median of 9 months versus a median of 3 months, again, tripling in terms of PHP. And then the overall survival, the 1-year overall survival was clinically beneficial for the patients with PHP, but not significantly different. And again, it wasn't really powered because we did have to pivot to a single arm trial. Overall survival based on response, the patients with complete responses obviously don't have a median survival in this study. Partial responders, 24-month median progression-free survival. So the better you do, the earlier we see the patient, we've known in this procedure as well, burden of disease matters. We even looked at our subgroup analysis. So burden of disease in the liver, extent of liver involvement, patients with lower median hepatic tumor burden did significantly better in terms of objective response, progression-free survival, and overall survival. So getting these patients earlier, doing PHP, same theory, same principles. We're not burning the bridge for any escalation of therapy, but we might be able to select out a population that will never need other therapies, or at least delay other therapies. So here you can see progression-free survival did not differ based on prior therapy, extrahepatic disease, or extent of baseline liver involvement. Overall survival did not differ based on prior therapy or extrahepatic disease. However, it was significantly improved in the extent of baseline liver involvement, so the sum of the maximum diameters. So in conclusion, PHP with melphalan shows the statistically significant improvement in overall response rates, 3 times better than best alternative care. Disease control rate 2 times. Progression-free survival 3 times, overall survival when compared to BAC patients. PHP for metastatic uveal melanoma offers better hepatic disease control compared to other first-line therapies. I did not show you that data, but because I only have 45 minutes and probably overtime already. It's at least 2 times longer hepatic progression-free survival compared to combination immunotherapy or monotherapy immunotherapy. It continues to offer better hepatic and progression-free survival, even if it's used as second line compared to second-line IO or liver-directed therapy. And patients respond favorably to PHP despite use of previous therapies or extrahepatic disease. And the last 2 slides or so, I'm going to skip a few here. Future directions, definitely, I think, combination of locally and regionally delivered therapy, aka RP1 plus Nivo, is the next phase in treating these really difficult patient clinical scenarios. There's evidence of PHP plus Nivo in the Chopin trial. We have an IIT of PHP plus Tebi in patients who are HLA positive. The IGNITE-3 trial, which is the RP1 plus Nivo, to me showed a huge clinical benefit for these patients with a really bad problem. I'm going to go through that. And this is just our Moffitt IIT, which is 2 PHPs followed by a year of Tebi, followed by patients PHPs 3 through 6 if they fail Tebi. And we're going to correlate that with correlative science, core biopsies, single cell analysis by Kieran Smalley's lab, stuff that I am, as a simple surgeon, very unfamiliar with. So the future is bright. Several up-and-coming new therapies, TIL, hopefully RP1 plus Nivo, a lot of combination strategies going on, sequencing of these therapies. Does regional come first or systemic? Or is it sandwiched? Those are really the future of treating these difficult to treat clinical scenarios. And thank you again for your invite and the opportunity to come to your great meeting. I appreciate it. And I talked very fast, but I'll be happy to answer any questions.
Other questions? Okay.
Yeah, John, is there any experience with this new histotripsy apparatus and approach for liver metastases of melanoma, whether uveal or otherwise?
I'm going to give you my biased view. We know that metastatic uveal melanoma to the liver is miliary. It's peppered. The whole liver is peppered. When we used to do open liver perfusions, you open the patient, you do an open cannulation of the liver, and you can see the liver is dotted with very small black metastases that are not seen on imaging. They're too small to be seen. So histotripsy is a method of identifying small visible metastases and then blasting them with a technique. But I don't think that that's appropriate for metastatic uveal melanoma. I can almost guarantee you start histotripsying, a right lobe lesion, 3 months later, you're going to have multifocal disease. Not because you made that happen, just because that's the natural history of this disease. So I'm not in favor of resecting or doing histotripsy for these patients. I think it's the wrong thing to do, actually.
I have a question for you, John. The hepatic infusion you'll do multiple times, but limb you seem to just do it once.
Right.
Is there any thought of multiple perfusions of the extremities?
Yeah, so the Australian group at Melanoma Institute Australia did do timed repeat ILIs, and they didn't see that it was any better than the single use. What I do, and I've done it several times on several patients, but I base it on if you have an ILI and you respond, in 6, 9, 12, or whatever months later, you start to progress again or recur. As long as I know that you've responded to melphalan and you didn't have any toxicities, I'll try it again. I won't do it as a timed repeat ILI, and I won't do a repeat ILI in patients that just progress right through it at 3 months. I refer those to MedOnc.
And then I have two other questions. Number one, is there any thought of other agents to infuse?
Yes, so in ILI, we've done plenty of clinical trials with other agents. None have shown to be better than the tried and true, melphalan of the 1960s when perfusions were first brought about in Tulane. So that's really the best agent. There's been several agents that have been used both with liver and in limb, and none seem to be better in terms of efficacy or toxicity as opposed to melphalan.
And then my one last question, what is your limitation of injectable things? In other words, you just use TVEC on skin, lymph nodes, and certainly the data with RP1 suggests it's likely better than TVEC, or maybe. And so is there any limitation of what you could actually inject?
Yeah, so with TVEC, it's limited to cutaneous, subcutaneous, and nodal metastases based on the FDA label. As far as RP1 is concerned and the IGNITE trial, you can inject anything that the IR docs can get a needle in. So deeper metastases.
How about your guys' experience?
We will, so since it's not approved, FDA approved, we will do it if and when it becomes FDA approved. And on trial, we do injection of visceral metastases. Absolutely.
Any other questions?
Jonathan, thank you very much for a great presentation. Some of the data that you've reviewed is eye-opening. The question I had was that individuals or patients who fail ILI and they go on to subsequent immunotherapy systemically, do you have any data or sense of what their outcomes are with immunotherapy?
As second line.
As a second line or...
Yeah, we're looking into it. So we do have an idea. I mean, again, these patients that represent a patient population where the biology of disease is just different. So did you fail ILI because you just progressed regionally? Your 10 dots of in-transit metastases are now 20, or did you progress systemically? Those are two really different scenarios. Patient A, we can put on TVEC, maybe do RP1 plus Nivo if it ever becomes available. Well, they have to fail systemic therapy. Patient B, there's no other choice. We're putting them on systemic therapy. So we are looking into it. It's a very mixed population. We have to have a logical approach to it.
I do wonder if some of those patients that are failing only regionally are sort of more indolent disease rather than hyperproliferative disease that's going into visceral, organs and such.
Agreed, yeah. So those patients that, again, I see the patient back usually via Zoom at 6 weeks and then in person at 12 weeks with a PET scan. And if they've failed ILI at 12 weeks, meaning they're progressing, whether it's regionally or distantly, we'll pivot. But some of the patients who are just progressing regionally, and now we're giving them yet even more time to show us that they're not that biology of disease that's going to progress systemically, I'll offer them TVEC. Which I think is perfectly appropriate for those patients. Again, with TVEC, it's even better. You see them every 2 weeks. You're going to know if they're progressing right then and there. We see them. We're injecting them. It's not like a liver met that you're given Nivo, Ipi-Nivo, Pembro for, and in 3 months you're going to scan to see if it's going away. We know if it's working right then and there. We can pivot very easily.
Any other questions? Again, thank you very much, John. Thanks for being here.
It was a pleasure. Thanks.
So, as we mentioned, we switched the order. So next will be Dr. Margolin, who's my colleague and an esteemed medical oncologist, is going to talk about promising approaches in vaccines and novel immunotherapies. So thank you, Tim.
So promising data on vaccines and other novel immunotherapies, and I'll warn you ahead of time that I'll be popping through a couple of the slides which turn out to be redundant with some things that you're going to hear from other speakers in greater detail. So these are my disclosures, and as they say, the more disclosures you have, the less conflicted you are. Most of them are DSMBs and single and mock ODACs, actually. So this is the first one I'm going to skip at the very last minute. Some things got turned around, but you're going to hear much more about circulating tumor DNA and other genomic and sequencing types of information from Matt Hedberg a little bit later. The first several slides were taken with permission from Nikhil Kushalani, who's actually another great investigator from Moffitt, where John works, and he's been leading much of the work on RP1, which you just heard about. So some of these slides were used at a talk that he gave, many talks that he's given, and then of course some of those were adapted or adopted from other presentations. Those of you in the audience who are medical oncologists, and some of the others will undoubtedly recognize this well-recognized slide from the Checkmate 067 trial, which has really set the stage and pretty much the threshold or the bar that we use for studying other agents in metastatic melanoma. This publication came out, this is a follow-on actually to something that first came out in approximately, I would say around 2013 maybe, frontline therapy using ipilimumab and nivolumab or ipilimumab in advanced melanoma, irrespective of BRAF status, but taking that into account as you see if you read the paper, but I didn't put into the slides. But this basically shows that there's a big difference in the overall survival, and other slides show the progression-free survival in advanced untreated melanoma between ipilimumab and nivolumab, which is currently still the gold standard, but unfortunately still the gold standard for toxicity of an immune-related nature, versus what you get from single-agent PD-1 blockade, which isn't all that much worse. And then ipilimumab didn't make it really well as a single agent, and we almost never use it any longer as a single agent, but it's still recognized to be a very important component of many of our combination therapies, and many of the investigations that are currently going on are to either make a better IPI or to find a different immunomodulatory agent that can synergize or add in a similar way, maybe less toxic, to PD-1 blockade. And these are the results of initially a look-back study shown on this waterfall plot, in which investigators based in part in University of Chicago, but also you see Nick Kushlani's name at the bottom, and Jason Luke, who's at Pittsburgh, was at Pittsburgh, he's now in industry, in which patients whose disease progressed on PD-1 blockade were then given ipilimumab plus nivolumab, and the response rate was around 30%, with a median survival of about 25 months, and these were 70 patients, as I say, not on a prospective trial, but in the subsequent picture you see the result of a SWOG-led, Ari Vanderwald as a first author, trial of crossing over, in this case, patients with metastatic melanoma whose disease was refractory to first-line PD-1 blockade, who then were assigned to either full-dose ipilimumab plus nivolumab or ipilimumab alone. So it's similar to what you just saw in the look-back study, and you see that there's about a twice as high response rate to the combination as there was to ipi alone, and there appears to be a plateau that looks more favorable as well. So that has also become the standard second-line therapy for patients whose disease fails to benefit long-term with single-agent PD-1. Whether the results are going to be even better when patient's disease is not refractory but has an acquired type of resistance, where the patient responded initially to single-agent PD-1 and then progressed and then received the combination, is likely but not yet fully proven. It's been difficult to do studies that, to have all the studies go into silos of purely PD-1 blockade resistant patients and PD-1 blockade initially responsive and subsequently resistant, although attempts are being made to define those because they may be behaving quite differently. So here's a summary that Nikhil put together in which has some of the immunotherapy options for refractory disease, and we'll come back to talking a little bit about lifileucel. I will not be talking about the combination of anti-LAG3 with PD-1 blockade. It's sort of an intermediate and not very good salvage regimen, although some newer and more investigational anti-LAG3 together with PD-1 blockade are being tested but haven't yet reported out. I would like you to look carefully at this slide that's almost impossible to read and memorize it, especially those of you who declined to come and sit in the front of the class because you were afraid you might get picked on. But this is it. This is immunology, and in fact, there's even some targeted therapy over towards the right. If you can squint and see that the JAK-STAT, that the many JAK-STAT pathways in the tumor cell are also featured here. But basically, there's a lot of molecules here on the surface of cells that interact with each other that are very important, and the critical thing is to look at the dendritic cell as the key antigen-presenting cell. I don't know if you can see my cursor there. The T cell here interacting with dendritic cells in order to become activated in response to the presentation of antigens on the HLA molecules of the dendritic cell, together with some other co-stimulatory molecules, and then a bunch of other cells in the tumor immune microenvironment, including B cells and many different types of T cells, subsets of CD8 and CD4 cells, and then over here, the T cells all ganging up on the tumor cell in different ways, ultimately resulting in signaling inside the tumor cell that leads to the tumor cell's death. Sorry about that. And that's all of the principles of tumor immunology. So I actually had quite a few slides regarding the use of RP1 as a viral oncolytic virotherapy. But thankfully, Jonathan already took us through much of those data. I want to just focus again on this slide because this breaks up the groups of patients into quite a few different categories, although I believe many of them are overlapping with each other. For example, primary resistance, as I just described, and PD-L1 greater than or equal to 1%, for example, aren't necessarily separate groups of patients. They're partially overlapping groups of patients. But the bottom line is that with a little imagination, almost all of the groups as they were defined had approximately the same response rate overall to RP1 injection, and that was in the realm of about 30 to 35%, with those plateaus shown in the next slide and shown by Jonathan that suggest a fairly durable response. And the company that has been developing this RP1, which if you want to know all the details, I suggest that you ask Kelly Mahuron, who I'm looking at right now. She's an expert surgical oncologist at City of Hope who works on oncolytic virotherapy and can explain the genetic alterations in RP1 and how they compare with TVEC. They're herpes viruses, they have GM-CSF, but there are some other interesting alterations. And what you see here in this kind of interesting waterfalloid plot is red and blue representing injected and non-injected lesions, I think in opposite order. Blue is injected and red is non-injected. And this shows, I think better than anything we know about TVEC, that there is a definitive distant effect in the use of this form of oncolytic virotherapy intratumorally injected. In the next slide, next two slides show a couple of spider plots. Interestingly, again, injected is blue, non-injected is red, and the kinetics of response is similar. The fact that non-injected lesions, just as you saw on the previous slide, often respond is shown here. But look, let your eyes kind of drift back and forth, and I think I can see that responses are deeper in injected lesions than they are in non-injected lesions. Of course, there are more data points for the non-injected lesion spider plot. And in this slide, which breaks out some of the spider plots for the non-responders, you can also see that patients who did not enjoy an overall objective response by RECIST criteria still had some lesion reduction in the non-injected lesions. So it's kind of exciting, and in fact, I I will skip this slide. These two, the safety profile is quite good. And this is just a little bit of the science in which it was shown that the gene expression profiles that reflect the induction of interferon gamma, one of the most important criteria for a highly effective anti-tumor immune response, was increased in these patients, particularly in the responders. T-cell clones were shown that were both expected and unexpected, and some kind of epitope spread or antigen spread was also shown. But what we learned, in addition to these key takeaways about responses in injected and non-injected lesions, is that it's hard to predict what the FDA is going to do, and it may do something very, very different today than what it did yesterday or 10 years ago. So there's been a great deal of disappointment with the very recent FDA disapproval of the RP1 request for an accelerated approval, for which their post-marketing phase 3 study that's required of all full approvals that had previously gotten accelerated approval has already been well underway. Thankfully, there's still a expanded access program for those patients who meet most of the same criteria. It's a single-arm study. We have it open at our institution, but for reasons of my black cloud and problems with eligibilities, I haven't yet been able to treat any patients. So a couple of slides from what was promised at the beginning of the title of this talk, which is immune approaches to the treatment of metastatic melanoma, as well as in the adjuvant setting, where sort of personalized neoantigen-based therapy really got its start. This was before the field was kind of turned on its head from the idea that you could do a better job against micrometastases in adjuvant therapy than in macroscopic disease. Now we know that just the opposite is true in humans, although animal experiments had told us, had suggested that the reverse was the case. So going back a bit just to the concept is what this is. What is an individualized neoantigen therapy? Well, you can't see it very well in this slide. I can't even see it very well on the cheater screen on this slide, but basically tumor is used from the patient, him or herself. The genomic signatures are used to define neoantigens that are generally based on single peptide or single base mutations in the DNA. And from those sequences, manufactured epitopes can be made. Actually, they're made based on the mRNA, the messenger RNA. You don't have to use the protein epitopes to make the vaccine, which had been really done more in the past. And all of this, of course, is based in very similar technology to the existing COVID vaccines. In fact, I think the COVID vaccines took their approach from what was already going on in cancer, and the same people sort of veered off to do the mRNA vaccines that we've used quite successfully in COVID. And if you want to be able to look at this a little closer, I'm happy to provide my slides to you or the references. But basically, these are the results from a randomized phase 2 study that was done in the adjuvant setting for resected melanoma patients with stage 3 and higher, by Jeff Weber, et cetera, who is looking down on us from heaven and hopefully still happy about what we're doing. This is the combination of the V940 mRNA, which has something like 34 encoded around 34 epitopes, and when combined with PD-1 blockade in the form of pembrolizumab, appeared quite superior to pembrolizumab alone, which is still the gold standard for post-operative adjuvant therapy for most stage 3 melanomas. And we now have, this is the distant metastasis-free survival, which is another form of looking away from what happens locally. One of the most world-famous surgical oncologists I've heard to get up in the audience of big conference rooms at big meetings and say that if you have a local relapse, it's the surgeon's fault. If you have a distant relapse, it's the therapy's fault. John, you and the others can decide if you believe Alex Egermont's statement to that effect. A few more words about vaccine therapy, which came out in a paper that Aneta was kind enough to get for me at the very last part of the day yesterday, which was from a publication in either one of the Cell journals, from the group that has led a lot of this neoantigen-based melanoma work at the MGH with Kathy Wu and Patrick Ott. They looked at 10 patients with untreated melanoma, 8 of whom had no evidence of disease, and looked at, what they looked at here was what comes after the mRNA. So it was a personalized synthetic long peptide vaccine. The long peptides are used because they encode both class 2 epitopes that generally interact with CD4 cells and class 1 epitopes that generally interact with the cytotoxic CD8 cells. And we know from other studies that both CD4 and CD8 responses are critical for the best outcome in cancer immunotherapy. But what's important here, and what I may or may not remember to mention at the end, so I'll mention it now, is that we're finding that the use of drugs that activate dendritic cells and other antigen presenting cells like B cells through their toll receptors, which are receptors either on the cell or in the cell, and they come from something that's called pathogen-associated molecular patterns, which we actually relate to the innate immune system, the ancient immune system that protected us against infectious organisms. But you can take pieces of those or elements of those structures and highly activate dendritic and other antigen-presenting cells, and those interact very nicely in a positive way with forms of cell immunotherapy and cytokines and so forth. Their niche is not yet proven, but this study used montanide, which is a form of Freund's adjuvant, and poly-ICLC, which is a form of double-stranded RNA. And they showed, this was purely for immune-based outcomes, but it showed ex vivo T-cell responses when studied against specific antigens, but they included CD8 cells, against the immunizing neoepitopes, but importantly, quite a bit of epitope spread. So in other words, when the immune response gets activated, those T cells and their antigen-presenting cells will react against all sorts of other things that were not present in the vaccine, and that's the root of a lot of the successful immunotherapy that we're doing these days. And then just the last few, tumor-infiltrating lymphocyte therapy. You've heard a lot about it, I think, and so we'll kind of gloss quickly through these slides. Here's a sort of a longer-term follow-up in 2025 of the initial lifileucel, which is the approved form of tumor-infiltrating lymphocyte therapy, in which a tumor must be harvested, taken to the lab, placed in interleukin-2, the T-cell growth factor. The tumor cells die, the T-cells grow and expand. They're given back after a sort of a medium-high dose chemotherapy that is intended to lymphodeplete the blood of the host who's getting back the TIL cells, and then the TIL cells are given back with a little bit of high-dose IL-2. In the PD-1 refractory setting, here is the response rate and the plateau. And this, again, is sort of a first out of the gate approval upon which many, many different attempts are based to make this better, less toxic, less expensive, less cumbersome, faster, et cetera. And this I just said. I think we can skip through the dermatology other than to give Susan Sweater a lot of credit for leading this sort of burgeoning field of applying artificial intelligence methodologies to attempts to better distinguish melanoma from non-melanoma skin lesions and find ways to, again, to do less surgery, de-escalate surgery. You see a classical, dysplastic nevus, probably syndrome patient here, but it's not feasible to take off all these moles. Many of them will not turn into cancer. And just a final slide about the possible future of early detection of melanoma. This was a mistake because of what I said earlier. This is a ctDNA study that I think you'll hear about more. So on that, I will conclude. Thank you for coming. Enjoy the rest of the seminar. And I think next we will be introducing Mehmi from the Angeles Clinic, Stellar Melanoma Group, will be speaking to us about some of the, what we might call alternative melanomas, uveal melanoma and acral melanoma, those that are very challenging and beget brilliant answers to questions that we haven't yet overcome. Thank you, Inder.
Hello, everybody. I'm Inderjit Mehmi. I'm a medical oncologist at the Angeles Clinic, and affiliated with Cedars-Sinai. I primarily see melanoma there of all sorts. My interest is in uveal melanoma. I'm the uveal melanoma lead there. So my job today is to cover 3 different diseases in about 20, 25 minutes. I'll try and do my best. I think I got some help from Moffitt folks and Kim because they covered some of the material that I was going to, so we'll just skip over. I have about 60 slides, so bear with me. Okay. So the objective today is to cover 3 different disease spaces: uveal, mucosal, and acral. Luckily for us, they're not very common. The typical skin melanoma is still common, and that's the one that requires most attention, and it does get more attention. But these small disease spaces we don't have that many patients in it, so that makes it difficult to do clinical research, get drug developed, and improvement in outcomes. So uveal melanoma is the first upper bat. So it's not the most common, but it is the most common tumor of adult eye. In pediatric patients, it's the retinoblastoma and other cancers, but in adults, it's the most common, but it represents only about 5% of all melanomas. The key thing here is that the 50% of patients who are diagnosed with uveal melanoma will go on to develop metastatic disease, and predominantly in the liver, either alone or in combination with other. Lung seems to be the second organ where it sort of has predilection to. So those are the strategies that we take for treatment and surveillance as well. There's also been a good amount of steps taken and progress has been made how to prognosticate these patients, of who's at high risk of recurrences, who are patients who are going to do well in the long run. Previously, we used to look at the size of the tumor, which is sort of a thing that we do for all malignancies. But here, successfully shown that if you look at the gene expression profiling of the uveal melanoma lesions, that you could do a much better job at classifying these tumors. They're classed as class 1, and then they're subdivided into 1A, 1B, and then class 2, which is subsequently subdivided similarly. And as the class goes higher, in addition to another antigen positivity called PRAME positivity, you can actually pretty successfully determine who's going to recur in the next 3 to 5 years. For example, I saw a patient yesterday in clinic, a 60-year-old male came in with right ocular melanoma. At the time of his plaque therapy, had a biopsy, a small biopsy to do the gene expression profiling, and he's placed at PRAME positive class 2 uveal melanoma, and his risk of recurrences at year 3 is about 30 to 40%, and year 5 is almost up to 60 to 70%. So those are the patients that are going to need your attention in terms of your surveys, what to survey with, how often. There's no prospective data that we have, so recently we completed Delphi sort of recommendations due to be published soon, and we're looking at essentially high-risk melanomas. Uveal melanomas will require an MRI with contrast of the liver in combination with the CT of the chest for class 2s and high-risk class 1s, but that should be publishing soon. Because this is a rare disease, not a lot of patients, luckily, it does make it challenging to come up with adjuvant therapies to reduce risk of recurrences, especially on those high-risk patients, but now we're getting better. With gene expression profiling and TNB staging combination, we're defining these high-risk patients, and we can come up with some adjuvant strategies to see if we can reduce the risk of recurrences. Even before that, Dr. Zager and also Kim talked about, Dr. Margolin talked about neoadjuvant approaches and can we apply from cutaneous melanoma to uveal melanoma too. And one of the studies that I'll talk about a little bit later, the IDEA 196 with crizotinib study, actually had patients with metastatic disease, also had their eye tumor intact, ended up getting onto the trial and showed benefit in the primary tumor in the eye. And it's still early on to see if it's going to be with similar outcomes as neoadjuvant immunotherapy in cutaneous melanoma. The story is still developing, but they did see the eye tumor itself decreasing in size. And so they are going with the neoadjuvant option, but their endpoint's a little bit tricky. They want to look at the eye preservation, organ preservation, rather than any kind of relapse-free survivor down the road. And there are a couple of other issues with the trial that we could talk about at a later point. The other neoadjuvant option is, currently the tumor is treated with a plaque therapy, which is a radiation-based therapy, or proton therapy, again, to minimize the adverse events to the surrounding tissue. This is a neoadjuvant approach where you're injecting a compound Belstar AU011 into the tumor versus control, and then activating that particular molecule with a laser diode at 689 nanometer wavelength. And then what it does is that the interaction of that molecule allows the tumor to die, and that death is both immunogenic and non-immunogenic. And we care mostly about the immunogenic death because now we're thinking that that would allow our immune system to learn to deal with any of the micrometastases down the road. So if you haven't had the option of neoadjuvant therapy and you've gotten your primary therapy with brachytherapy or proton therapy, there have been a number of adjuvant studies in uveal melanoma that have been carried out, but not many are in practice, and mostly because either they were too toxic or their benefit is limited in most of the patients. The trial that actually was probably the most exciting in the last 2 to 3 years is by our colleague at Georgetown, Suthi Rapsawan. He looked at high-risk uveal melanoma and treated them with the nivolumab every 2 weeks, with ipilimumab every 6 weeks for a total of 48-week therapy. And the primary endpoint for this trial was disease-free survival at 3 years, with a secondary endpoint of median distant metastases-free survival, OR survival, overall survival, and toxicity. When you look at the results of the study, you can see that the 3-year DMFS versus the control, sort of a database control, is 69% versus 45% without any adjustment. But when you adjust for a number of factors, you can see that that actually control is 70 versus 43%. A very good sort of out-the-box adjuvant option for high-risk uveal melanoma patients. I love the statement that Dr. Margolin made earlier, that Ipi-Nivo is our poster child for benefit in all melanomas, essentially, but to some degree not in uveal and mucosal. We'll talk about that later, but at least in cutaneous is the poster child, but it is also the poster child for toxicity. All the time we beat up on Ipi-Nivo for its toxicity. We compare all subsequent options that we're trying to bring forth. How little toxicity can we cause compared to Ipi-Nivo? And here too, for somebody who does not have any radiologically detected disease and trying to give them Ipi-Nivo, even though this dose is fairly low, the risk of toxicity is less than 20-30% compared to the Checkmate 511 dosing or Checkmate 067 dosing. Still very well tolerated, but significant toxicity burden, endocrinopathies, and other inflammatory mediated toxicity in other organs. The frozen time will not count against me. Help. It's welcoming me to Outlook. Thanks. I thought it was better than that at computers, but apparently not. Okay, so what's for the future in terms of adjuvant therapy? The two trials that I'm pretty excited about are two separate trials for two different populations of patients. Both are looking at high-risk uveal melanoma patients that have been treated for their primary disease. The first study on your left is the epigenetic modifier Quiznostat. It's an HDAC4 inhibitor. What the heck is HDAC4? So when you're looking at about 80 to 90% of the uveal melanoma will have a BAP1 mutation, and that mutation allows activation of number of metastases driving genes, and HDAC4 plays an important part in that. So when we use this Quiznostat, that inhibition leads to downregulation of those metastases driving genes, and that's been proven in sort of tissue culture petri dishes based testing, and now we're taking it to the clinic where we're looking at these high-risk 2 gene expression profiled 2 patients and treating with Quiznostat at 12 milligrams capsule taken orally 3 times per week, 21-day cycle, total of a year of therapy, and the endpoint is DMFS, and the secondary endpoints being PFS, OS, recurrent sites, and adverse events. In the prior studies that have done with Quiznostat, most of the toxicity were more tachycardias, not any of the significant or sustained arrhythmias, in addition to some mild myelosuppression. The other option adjuvantly that's coming forth is with tebentafusp, but we know that it has been established as first-line HLA-A*02:01 positive patients with metastatic uveal melanoma in metastatic setting. So here we're trying to see if we can treat these high-risk patients early on to reduce their risk of recurrences. Again, looking at high-risk uveal melanoma patients that are HLA-A*02:01 positive, and you treat them with tebentafusp for 6 months and with the endpoint of RFS, relapse-free survival, and the secondary endpoint listed as. So once, you've got these adjuvant options, they help us or not, so eventually some of those patients are gonna have recurrence of disease, mostly in the liver, and there are a number of different options, different ways to embolize some of these tumors, and also infusions that, people much smarter than me, surgery folks have explained this to you, in a detail. So, but there are a number of options that are available to treat the disease within the liver itself. Thank you, Dr. Zager. This is something that you've done already. Saved me some time. So this is the second trial. Similarly, it's a liver perfusion study. Again, showed very good benefit. So we'll skip over this. And this is sort of the hot data that was presented at FASCO this year by Dr. Cedar from Thomas Jefferson, looking at different types of immunoembolizations or other embolization procedures for liver-only disease, and sort of retrospectively compared these outcomes to tebentafusp alone, and they matched fairly well, but I caution you, this is a single institute study. I don't know how much to put weight on this. So Period 1 study is actually very interesting. Something that Dr. Margolin hinted towards is the TLR 7 and 8 compound SD101. I was part of this development back in 2015, 2016, when we were looking at intralesional injections of SD101 into refractory melanomas with pembrolizumab. And the company shut down because they ran out of money, and eventually somebody else bought the SD101 rights, and now they're going after uveal melanoma with a pressurized delivery system. And they looked at 33 patients in this early phase study, at least one dose of SD101, and showed benefit in the uveal melanoma. The phase 3 study or phase 2 study, they're still in the process of recruiting. We'll see what happens with that. So there are always some different pathway aberrations in almost all of the malignancies, and uveal melanoma isn't foreign to that. We know that uveal melanoma holds GNA11 and GNAQ mutations. until I'd say for the last couple of years, we didn't really know how to take advantage of that mutation until we had the IDE 196, which is darovasertib, looking at controlling uveal melanoma in metastatic setting. This is the early phase study in the first line and in any line showing benefit. And now we have the phase 3 study going on in HLA negative, the patients who are not Tabenta FASP candidate, their metastatic melanoma, randomizing to a couple of different options of therapy. So this was a clinical trial that was discussed at ASCO this year, DYP688. It's a smart way to deliver the drug and smart way to interfere with GNA11 gene Q mutation. They're planning to look at the, obviously, dose-limiting toxicities, other adverse events, finding the dose itself, and preliminary anti-tumor activity. You can see that in a number of different dosing mechanisms, there is ongoing benefit from DYP688. What if you don't have an access to clinical trial? What do you do for these HLA negative patients with the metastatic uveal melanoma? You fall back on ipi-nivo, but it's only about 18% response rate that lacks the durability in a lot of situations. This is a single arm study that was from Dr. Patel's group at MD Anderson, showing benefit. Again, very limited amount of benefit in some patients, but the toxicity of 30 to 40%, especially colitis-oriented, it sustains. The second study of the same type was from Spain, looking at the benefit of ipi-nivo in metastatic uveal melanoma. Again, the same kind of benefit. So I think it'll be nice to know which patient I can give ipi-nivo to rather than exposing a bunch and catching only 5% of them for benefit. The study that I think is probably more exciting from a combination standpoint is something that Dr. Zager sort of hinted towards. It's the CHOPIN trial. It's looking at combination of ipi-nivo with PHP. 2 doses of PHP are given while patients are getting ipi-nivo. And the early part of this 7-patient cohort was reported no significant DLTs from other than what we know of, but there were very good responses, 1 complete response, 5 partial response, and 1 stable disease, accounting for objective response of 85.7%. And at median follow-up of 20 months, 4 patients had ongoing response, and median PFS at the time this abstract was reported was 22.4 months. So something to be very excited about. I think there is a larger sort of cohort that's going to get reported at ESMO, I believe. This is sort of the first, but this is the first therapy that was approved for metastatic uveal melanoma, but a very sort of small group of patients that are HLA-0201 positive. So it's restricted by that. And this was a 2-to-1 randomized phase 3 study. Control arm received pembrolizumab or ipilimumab or dacarbazine. They were treated until progression of disease or toxicity. Primary endpoint was very courageous overall survival for a therapy that hasn't been seen anywhere else. And it did meet its overall survival endpoint, and it's been FDA approved. And in practice, the toxicity related to this agent tends to be within the first 3 doses, and after that, most of the toxicity is skin limited. There's some next sort of second generation ImmTACs or T-cell engagers, and one of them is brenetafusp. The tebentafusp has a tag of GP100 that it recognizes here. The epitope is PRAME, and again, this is being studied in cutaneous, but we've seen responses in uveal melanoma. This data was reported by my colleague, Dr. Hamid. You might know him. This is the sister study of IGNITE-3 in uveal melanoma, and it's called REVEAL. And the early phase data showed that when you inject these uveal melanoma lesions in the liver with RP2, which has an engineered PD-1 and CTLA-4 into that herpes virus, it's able to control the disease in combination with nivolumab. The phase 3 study is ongoing, and it's open at our site. I'm sorry about the print here. I just took the whole abstract from ASCO and put it up there. It's OCUL1. This is one of the particular PI3 kinase inhibitors that leads to downregulation of T regulatory cells and increases immune response. This was a trial in progress, so we'll see more data as the time passes. Can't complete my uveal melanoma talk without saying very little about TIL. It's an ongoing study. There are some responses that are seen. The only site for TILs is UPMC at this moment, and we'll see what happens in the future. Again, I think there are going to be some uveal melanoma patients or tumors that are immune responsive. Perhaps those are the patients we're capturing with the TIL as well. Okay, done with uveal. Let's go to mucosal melanoma. I don't have a whole lot from mucosal melanoma. A lot of it is borrowed from cutaneous. Again, not very common. Tends to be a little more frequent in females. Sites could be respiratory, gastrointestinal, or GU tract. The diagrams below are not legible, but they're important. Different sites carry different genetic alterations. Okay, and that may play some role in our decisions of therapeutic options. We've seen a lot of benefit of adjuvant therapy in cutaneous melanoma, not so much in mucosal, until we look at adjuvant chemotherapy with Timodar plus cis. That shows good amount of relapse-free survival benefit versus other options of high-dose interferon. And also some overall survival advantage. But when you're looking at the phase 3 randomized controlled trial, some of that benefit dissipates. That may be delusional in nature, but it's an option that I do talk to my patients about. Anti-PD-1 as a single agent, as an adjuvant option, isn't an appropriate option. I don't even consider it. I don't think it provides you the benefit. There is a small risk of toxicity. So if there's going to be an adjuvant option, I think it's probably chemotherapy than immunotherapy or single agent PD-1. There are ongoing studies across the globe looking at adjuvant options in mucosal melanoma, and also looking at some neoadjuvant options, combining axitinib with PD-1, showing some benefit, but we need larger studies that can show us the benefit. Again, neoadjuvant option with pembrolizumab and lenvatinib, showing T-cell activation, CD3 and CD8, positive T-cells, hopefully down the road, we can have similar sort of approach where we can give neoadjuvant therapy and de-escalate some of the surgical options. These are some of the ongoing neoadjuvant options in mucosal melanoma. And we know about 25% of the mucosal melanoma will harbor NRAS mutation, one of the MAP kinase pathway enzymes. And there are a number of different ways to sort of leverage that for therapy. We have a couple of different trials that are looking at any NRAS mutation and using either pan-RAF inhibition with MEK inhibition or downstream MAP kinase inhibitor to leverage this mutation as a therapeutic option. So some of those, I believe 15 to 20% of the mucosal melanoma will have a c-KIT mutation, and that could be managed with imatinib. We do that quite often, but there is ongoing studies and some established data with combination of imatinib with PD-1 with disease control rate of 80% in a small subgroup of patients with 34. And there has 47% of these were mucosal melanoma patients that had, again, 80% disease control is something that we can consider down the road. When you're looking at what's available to us already, Checkmate 067 had mucosal melanoma patients, but their benefit was limited. And so what else can we look at? You know, the angiogenesis plays a very important role in mucosal melanoma for a number of different reasons listed there, from vessel formation, endothelial activation, T-cell exhaustion reduction, and remodeling the suppressive tumor microenvironment, et cetera. And for that reason, there have been a number of different trials looking at PD-1 and combining with the different sort of molecules that target the VEGF pathway, showing benefit. I'm highlighting 3 trials here that looked at apatinib or bevacizumab or axitinib as the counterpart for VEGF inhibition with a number of different PD-1s showing benefit. All of these trials have been small and sometimes ex-US, so we don't know what to make of the benefit of this, but something that we do consider in our patient. And all these studies are in the first-line setting as well. The toxicity to consider is with the VEGF targeting is, you know, hypertension, proteinuria. You got to worry about bleeding risks and such. So this is another developing story with TIL in mucosal melanoma. There were 12 patients treated. 50% had overall response. Median duration of response was not reached. I believe they just updated this data in JCO recently, showing larger set of patients with ongoing benefit. It's something you can consider for your patients, but it's very selective because when you're looking at TIL application, the non-myeloablative chemotherapy does beat them up, and subsequently they get beaten up by interleukin-2. But reasonable option for your fit young patients who don't have a large comorbidity index. Shaping the future of clinical practice by various number of clinical trials that are ongoing. So we look to the last trial, Artistry-6 is a dud. It did not meet its endpoint. Hopefully, we'll get better results from the others listed. Okay, last topic. Ooh, I have time. Acral melanoma. So acral melanoma is another rare form of melanoma. That's the non-hair-bearing skin melanoma or nail bed apparatus melanoma. There's some benefit from adjuvant radiation to the local regional lymph node, even though it's not practiced, at least we don't practice a lot. It does not change any of the distal metastases, so that's perhaps one of the reasons. Number of different trials that have included acral melanoma, and this is the sub-analysis, looking at a number of different options as a single agent PD-1 or in combination. The benefit is not as robust as you see from Ipi-Nivo in cutaneous melanoma. Relativity 047 with the nivolumab and relatlimab also included acral melanoma. The group I'm indicating here is above the arrow. Again, showed limited benefit. And this is a publication that I was part of, looked at adjuvant PD-1 versus observation in the adjuvant setting, and it doesn't seem like it's any better than observation, but we continue to use PD-1 as an adjuvant option in this particular setting. What to do in the first line setting? This is, I believe this was a retrospective trial with the pooled data of 143 patients. Again, first line therapy with PD-1 with limited benefit, which is kind of expected. I mean, in melanoma, we know that there are only few group of patients that actually have a robust response with single agent PD-1. Most of the time we tend to leverage Ipi-Nivo or a combination approach. Here, one of the retrospective analysis is looking at first-line combination immunotherapy versus single-agent PD-1, and doesn't seem to have a lot of difference in terms of some of the progression-free survival with PD-1 therapy, but it seems like there may be better outcomes with overall survival with ipilimumab with nivolumab versus PD-1 alone. Again, you do have to worry about the toxicity, so selection of patients is quite important. Target therapies, this is not a disease space where there's a lot of mutations present. Acral melanoma, it tends to be the tumor mutation burden tends to be low. So the target therapy options, even though they're good when present, but the options are only for few patients. This is one of the retrospective study that I was part of looking at efficacy of PD-1 and ipilimumab alone in combination in acral melanoma. Again, similar story that the benefit isn't the same as what we see in cutaneous melanoma. Anti-PD-1, ipatinib, and Temodar, looking at acral melanoma, 200 patients. It seems like the chemotherapy option is something that we can look into more with a larger trial, as well as the TKI ipatinib. The newer approaches are looking at TVEC in these situations and some of the other newer molecules with bispecifics and tumor-infiltrating lymphocytes. Again, we need prospective trials. It's a small subset of melanoma. It doesn't get the attention that it needs. Future studies will help us guide with better therapeutic options. And this is my summary.
Our next speaker is Dr. Hedberg, Professor of Pathology from City of Hope. He's going to talk about liquid biopsies. So thank you very much for being here today.
Well, we're getting set up. My name's Matt. I'm a recent transplant to City of Hope from the University of Pennsylvania, where the majority of my work was actually in non-melanoma skin cancer. But Dr. Margolin asked me to come talk about ctDNA in melanoma today, I think in part because it's been a recurring subject of conversation at our tumor boards, which she graciously attends, and maybe because there wasn't anybody available with actual expertise to do the talk. But either way, in the year that I've known her, she strikes me as a very kind and equally powerful person, so I said I'd take a crack at it. Let's see, is the center button? Oh, there's the laser. Okay. I have no disclosures. If anybody's looking for a consultant, I'd love to flesh this slide out. So when we talk about liquid biopsies, everybody jumps, I think, appropriately to like CTCs, EVs, ctDNA, all these kind of cutting edge things. But the concept of a liquid biopsy is not novel, nor does it need to be particularly complex. Every time you check a blood sugar, you're doing a liquid biopsy for diabetes. Every time you check a PSA, you're doing a liquid biopsy for prostate cancer. Depending on the analyte that you isolate, that determines what you can do downstream of that. You can actually test many more things in a circulating tumor cell than you can in pure circulating tumor DNA, for example. However, the complexity level and scalability of these tests is more challenging, and so I think in part for that reason, ctDNA has kind of led the way in terms of clinical development. And when we talk about ctDNA, that's circulating tumor DNA, that is the fraction of cell-free DNA that's in circulation. It was first described in the blood, I think, in like 1948. It has a short half-life on the order of 15 minutes to about 12 hours. It's generally about 120 to 180 base pairs, which is characteristic of apoptosis. So this is cells that are dying and just kind of shedding this DNA into circulation, which we then try to detect. When I think about ctDNA tests, I kind of paint them with kind of four broad descriptors. You have limited panel tests, which kind of look at very targeted things. We're just trying to find a BRAF mutation. We're just trying to find what have you, versus broad panel tests, which will look at dozens, if not hundreds. Actually, some of the platforms that are now coming into commercial availability are doing whole genome-based assays for ctDNA. And then each test is either tumor agnostic or it's tumor informed. A tumor agnostic test, you're essentially just testing that cell-free DNA and maybe some germline DNA so that you're not, inappropriately assigning mutations to the tumor that are just germline in the patient. But it's just a panel of genes depending on the test, and you're kind of hoping that when you run your cell-free DNA through this assay, that your tumor is going to harbor and be shedding one of the variants that this test is capable of detecting, as opposed to a tumor-informed test in which you sequence the tumor tissue, germline tissue and the cell-free DNA, so that you can then design essentially a bespoke panel of alterations to then try and track in subsequent liquid biopsy cell-free DNA assays going forward. The liquid biopsy process, we're not going to get too into the weeds here, but you extract the blood, you separate the components. The cell-free DNA is isolated within the plasma. If you're going to be testing some of these other elements, you'll look to other parts of the blood product. I do want to highlight that when it comes to ctDNA assays, techniques, methodologies do matter. Because the fraction of circulating tumor DNA is such a small component of the overall cell-free DNA, you have to have some pretty refined techniques to effectively detect those, especially if you're trying to find rare variant allele frequencies. You can't just Sanger sequence this stuff, you'll miss a ton. And in terms of, that didn't work very well. In terms of detectability of ctDNA in cancer, it varies for a number of reasons. I think honestly the biggest hurdle is that different cancers shed different amounts of ctDNA. Part of the reason that the body of evidence is so much more advanced in colorectal carcinoma for ctDNA is because those things shed like crazy. Melanoma is not the best shedder in the world. Other things that can influence the ability to detect ctDNA is the disease burden, higher disease burden, greater rates of shed, easier to detect. Disease location, there's many publications out right now that show your ability to detect metastases by ctDNA will vary quite significantly in some cases based upon where those metastases are. Are these liver mets, are these lung mets, are these bone mets, are these in the CNS? And then of course treatment. Typically treatment, if it's working, is reducing your tumor burden and bringing down those ctDNA levels. However, if you were to run a liquid biopsy shortly after a patient just got radiation, you're going to see an iatrogenically induced spike in those ctDNA levels, which shouldn't be interpreted as progression, evidence of progression necessarily. So we do have to be cognizant of the full clinical picture when performing and interpreting these types of assays. One of the malignancies in cutaneous oncology that happens to be a good shedder is Merkel cell carcinoma, and the ctDNA body of evidence is quite advanced compared to melanoma in this field. This JCO study had 300 patients divided into a discovery and a validation cohort. This used the Signatera assay, which is a tumor-informed assay, and they were able to detect disease in ctDNA at trial enrollment in like 90% of the patients, essentially. And then as they tracked the ctDNA serially after treatment, there was obviously a very pronounced survival benefit in both the discovery and validation cohorts in patients who became ctDNA negative following treatment, whereas those who remained positive or became negative and then became positive subsequently had lower rates of survival. When you pool this, there's the recurrence-free probability at 12 months is 9% in patients with a positive ctDNA at any time during surveillance, compared to 91% for patients who remain ctDNA negative, which is shown here. They also showed that the metric, which is mean tumor molecule for the Signatera test, every test has different metrics, but mean tumor molecule per milliliter of plasma correlated temporally with the recurrence itself, such that these higher levels were associated with recurrences that were more closely in time to those tests. And they were able to determine in this cohort at least a threshold where if you had a liquid biopsy that showed over 100 mean tumor molecules per milliliter of plasma, you had a 100% probability of either having had or about to have a recurrence within 90 days of that positive test value. Based off of this paper, as well as several others that were cited in the most recent NCCN guidelines, the NCCN guidelines for Merkel cell carcinoma now actually support, without explicitly mandating, the use of ctDNA assays in monitoring treatment response and for monitoring for progression of disease in Merkel cell carcinoma, citing a high disease sensitivity and prognostic accuracy for early detection of recurrence, and this can be used in both virus positive and virus negative MCC. In melanoma, the NCCN guidelines have not yet fully embraced liquid biopsies. However, in cutaneous melanoma, they do permit the use of liquid biopsy to assess for biologically actionable mutations if for some reason tumor material is not available. And then, as they point out here, ctDNA is being used to monitor treatment response and progression/recurrence in a variety of clinical trials, which we will speak to shortly. The figure on your left is another figure, one of the earliest kind of high-impact papers in Science Translational Medicine, I believe, from like 2014, where they were looking at detectability of ctDNA in the blood. And again, you can see a high variation of detection rates across cancers, with melanoma being able to be detected in about, having detectable ctDNA in about 80% of the small cohort of melanoma patients that were in this study. Importantly, these were all stage 4 patients with high burden of disease, so it's kind of the fattest target possible for detecting this. Comparatively, in this 2023 study, which used the Signatera assay in stage 2 and stage 3 patients, actually fewer than half of the patients had detectable disease in ctDNA at the time of enrollment in this study, and these were generally the patients that had bulky nodal disease with a lot of extranodal extension. Only a single patient with stage 2 melanoma had detectable ctDNA at baseline. And so this highlights why ctDNA is not your go-to for initial genetic workup of these patients. You would much rather have that initial tumor tissue to do your initial analyses. Where ctDNA kind of is beginning to shine is in the setting of measuring treatment response and disease recurrence. So jumping back in time again to a limited panel assay, this paper I think was like 2015, highlights the importance of what I mentioned earlier with respect to methodologies. So these folks developed a TACMAN assay for BRAF V600E detection. They initially developed it by studying 92 matched tumor blood pairs in all cancers, and it had the ability, 52 of these tumors ended up having a BRAF mutation, but they were only able to detect 30 of them in the blood. So not the world's greatest sensitivity. They thought, well, what if we go to a target-rich environment? They applied it to 22 known BRAF positive melanoma patients, tested their blood, and it performed even worse in terms of sensitivity. However, despite these limitations, they were able to prognosticate from this data. The patients who were ctDNA undetectable or ctDNA negative had better progression-free survival as well as overall survival than the patients who were ctDNA positive. Now, of course, most of this is just reflective of the fact that the ctDNA positive patients had higher metastatic disease burden, but in the small subset of patients where they actually had serial subsequent follow-up ctDNA testing on treatment, you can see that the ctDNA levels tended to correlate with treatment response and then either recurrence or, in this case, a patient who had progressive disease on therapy. So this was kind of one of the first signal indicators that there may be some value to this as a monitoring tool. Fast forward a simple 1 year, and this paper came out studying subsets of BRAF mutant melanoma patients who had available plasma that were enrolled in various dabrafenib, trametinib studies that are shown here. And in 76% of the patients, they were able to detect the BRAF V600E mutation in the blood. So we jumped from a detection rate of 50% to 76%, largely because this uses a technique called beaming PCR, which is a droplet-based PCR assay with magnetic beads and mutation-specific fluorophores that are read out on a flow cytometer. So it's just a more sensitive assay, and they were able to jump that detection rate from 50% to 76%. Again, as was seen previously, those that were ctDNA undetectable had better survival in all 4 studies, but they also had better objective response rates in all 4 studies. Again, highlighting the importance of using primary tumor tissue whenever available for that initial analysis, because if you were only going based off of blood, the patients who benefited the most from therapy in these studies wouldn't have qualified for said therapy because you wouldn't have picked up their BRAF mutation just looking at their blood. Another year or 2 afterwards, a kind of a more optimized version of beaming PCR was utilized to assess these 3 studies, and as you can see here, we're now able to get in these studies a concordance rate between tumor testing and plasma testing in excess of 90% across many stages of melanoma as well, using these kind of more precise methodologies. And in this 3rd study, they were able to detect 100% of the BRAF mutations in the blood in these 35 patients, and then they followed them with serial testing, and all patients who responded to therapy had the ctDNA become undetectable until they progressed. There were 18 patients that did progress during the course of this study, and of those 18, 15 patients had a positive ctDNA test during surveillance. 2 of the 3 that remained ctDNA negative progressed only within the CNS, so potentially a pitfall there that it may miss some brain mets. And in 11 of those 15 instances where the ctDNA became positive, the ctDNA preceded the clinical or radiologic detection of disease by an average of 177 days. Probably the best study for, or the best data for limited panel ctDNA testing in melanoma came from some of the exploratory analysis performed in the COMBI trials. These were essentially trials in which, more or less treatment-naive patients were randomized to dabrafenib with or without trametinib, and they had 345 patients where they had a baseline plasma sample available, and then of those 345, about 222 where they had another plasma from 4 weeks on treatment, and then they used the COMBI-MB essentially as a validation cohort. And what they achieved here was a detection rate of 93% at baseline, so we're getting pretty good at catching these things at baseline. And interestingly, in this trial, for the first time, those that were ctDNA negative did not have improved survival, suggesting that we're now at the point of okay, it's just a test failure. It's no longer reflective of, this is like a lower grade biologic disease. When they were able to identify high risk and low risk in terms of better survival, they did it by treating this as a continuous variable, and they were able to set a threshold of 64 copies per milliliter of BRAF mutation. And if you were above 64 copies, you did worse. If you were below 64 copies, you did better. And then similarly, if you look at rates of, quote, zero conversion, so patients who were positive at baseline, which was 93% of the patients, to those who became ctDNA negative following treatment, those patients who became ctDNA negative had much better survival and higher rates of objective response. So it is capable of monitoring response to therapy quite effectively as well, at least in this study. In the validation cohort, these were patients with brain metastasis. They established that 64 cutoff that they had previously established was also valid in terms of predicting survival for these patients. And then in the subset of patients where they had longitudinal follow-up liquid biopsies, ctDNA zero conversion was associated with best extracranial overall response, but it did not achieve statistical significance with respect to intracranial best overall response. Again, a word of caution with respect to brain mets. So jumping back now to broad panel testing, these are 2 swimmers plots. This swimmers plot is from that slide that I showed you, figure that I showed you a few slides ago, using the Signatera assay, in which only, I believe, 48% of patients were positive at baseline. But what you can see is that when you then use this technology to monitor while patients are on treatment, there were 7 patients that recurred during the course of this study, and 6 of the 7 had a positive ctDNA value on treatment surveillance. Similarly, this is another study that used the exact same platform, had 30 patients. Even fewer patients were positive at baseline in this study, only 25%, but I believe it was 13 patients recurred and 8 patients had a positive ctDNA. 8 of the 13 patients who recurred had a positive ctDNA on surveillance, and in all 8 instances, that ctDNA was detected anywhere from a week or 2 to up to 6 months before the recurrence itself was actually detected. ctDNA status at baseline, as well as after treatment, correlated with survival in this study, and patients who were ctDNA negative at baseline and remained ctDNA negative had the highest survival, whereas patients who were ctDNA positive at baseline but became ctDNA negative after treatment were the next, and then patients who obviously were positive and stayed positive, or who were negative and became positive during surveillance, had the lowest overall survival. This was a study where these folks actually used an in-house tumor-informed assay, and they looked at 65 patients who were receiving palliative immune checkpoint inhibitors, and 22 patients who got surgery and then adjuvant ICI. They collected specimens at baseline, and then after 1 cycle of ICI, and then after 4 cycles of ICI, there was some imaging here, and they actually collected some other markers. And when they looked in the palliative arm of the study, decreasing allele fractions, so a reduction in the quantification of measurable ctDNA between baseline and time point 1 was associated with improved progression-free and overall survival, and similarly, decrease in measurable ctDNA levels between time point 1 and time point 2 was also associated with increased survival, as opposed to patients whose ctDNA fraction was going up. ctDNA was also shown, at least in this study, to be superior to the LDH and S100 analytes. In the swimmer's plot from the adjuvant arm of this trial, 9 patients in the adjuvant arm did not recur, and all 9 of those patients were consistently ctDNA negative. 13 did recur, and 10 of those 13 had a positive ctDNA test. 6 of the 10 were before it was detected, the recurrence was detected clinically, and an additional 3 were detected either at the time of recurrence or within a week. Probably the biggest and best assessment of ctDNA testing in melanoma is in the exploratory analyses of the Checkmate 915 trial. This was a trial in which a little over 1,800 patients were randomized to either Ipi-Nivo or Nivo alone, and for these patients, they had a little over 1,100 of them for whom they had a ctDNA specimen collected at baseline, at week 13 on treatment, and at week 29 on treatment. This trial used a commercially available tumor-informed assay from Invitae. And in both of the treatment arms, you can see that the patients who were baseline undetectable, which was actually the overwhelming majority, only 16% of the patients in this study had detectable ctDNA at baseline. The ones who were negative at baseline had superior recurrence-free survival and distant metastasis-free survival compared to those who had detectable ctDNA at baseline. This is what the data looks like when you pool all the treatment arms together. And they then assessed for the sensitivity and specificity at 3 months and 24 months of ctDNA to kind of identify recurrences. And as you can see, it was highly specific, but the sensitivity in this trial left a little something to be desired. The way they determined this was they said all the patients who have recurred by 3 months are labeled A, all the patients who have not recurred by 3 months are labeled B, and then the fraction of ctDNA positive patients that are in A gives the sensitivity, the fraction of ctDNA negative patients that are in B gives the specificity. The other thing that they noticed was that, and we're speaking specifically about baseline ctDNA status here, the further out you get, the less predictive the ctDNA status is, the baseline ctDNA status is. Once you get past about 13 weeks on treatment, that initial measurement doesn't tell you as much about risk of recurrence. So they tried to improve this in a variety of ways. They also did a bunch of other fancy studies where they had an interferon gamma signature assay and a tumor mutational burden, and then through some kind of complicated multi-modeling, they were able to stratify this more effectively, which is very intriguing and I think, opens a lot of doors to future studies, but it's also very complex and probably a little tricky to scale. Luckily, if you just followed them with serial liquid biopsies, ctDNA status, you could get a similar stratification. And interestingly here, in what is again the largest cohort that I'm aware of in melanoma where ctDNA studies were assessed, it's actually the group who started ctDNA negative and stayed ctDNA negative, which has always been the #1 survivors in the previous studies. They're actually #2 here. The highest rate of survival was in patients who were ctDNA positive at baseline and became ctDNA negative on treatment, which is a little interesting. Just very briefly, there are 2 commercially available tumor-agnostic liquid biopsy platforms out there that are FDA approved. There are many other lab-developed tests out there that are probably equally good, but if you find yourself in a scenario where you need a liquid biopsy and insurance is an issue or something like that, these 2 are FDA approved. And then in terms of options for tumor-informed assays, there's an ever-growing number of companies that are offering these. Signatera definitely has kind of the most published data in terms of peer-reviewed studies to date and kind of real-world clinical application, but you'll notice that just according to these manufacturer claims of sensitivity and limits of detection, it's actually one of kind of the least sensitive assays out there. Personally am a little bit intrigued by this whole genome-based test that Tempus is in the process of kind of rolling out. And we don't have enough data to say, oh, this one's better, this one's not. I think, we definitely need some head-to-head studies on this to inform the field. But overall, I think there's mounting evidence that supports a role for ctDNA testing in monitoring treatment response and recurrence or progression, at least in advanced stage melanoma. And I think as we continue to develop better and better assays, those use propositions are probably going to get broader and broader, as has been seen in Merkel cell and colorectal. And then the integration of other biomarkers, I think, will also be important to further optimize our ability to kind of monitor treatment response. One area that I didn't speak about because of time, but EVs and exosomes, there's some interesting data in the literature to suggest that melanoma and melanocytes specifically, because of their neural crest origins and the secretory capacities of those cells, may actually shed more EVs than they do circulating tumor DNA. So I think that may be an interesting area of exploration in the future.
That was a great presentation. Clearly this is an exploding field. This is an exploding field. You can just see by the number of companies, new companies, the test becoming more sensitive. And I totally understand the value of the test in evaluating response to therapy. What we're seeing, however, are patients are requesting these tests as part of their annual physical. We're seeing primary care doctors ordering these tests. I'm just interested where you stand, particularly in high-risk individuals.
Well, as a pathologist, I thankfully don't have to face these scenarios. But I think, the holy grail of liquid biopsies has long been sought, and I think that has been a road that has been laden with more failures than successes. In terms of whether or not these are appropriate things to pursue in high-risk patient populations, I think that's a very valid question, and is probably worthy of some formalized study. But I can't give a straight answer to that. I don't think that any of these should be used as a screening test in the general population, certainly. But for some of these high-risk patients, and particularly, I guess, patients who have a history of disease, is it inappropriate to think about maybe developing a tumor-informed assay that you can use on that patient? I don't know. I might like it for peace of mind, but I think the data probably isn't quite there yet. Yep.
Kim?
It seems like the ideal, patients often ask, well, can't you do blood tests for cancer? These are patients with cancer, not a screening. And, eventually maybe the answer would be yes.
Yeah.
But the other thing would be if the price and the high negative and positive predictive values could be honed in further, it might be a way to avoid or order the extremely expensive and sometimes difficult to interpret scans and things that we do
Sure.
On patients. Wouldn't it be great if we didn't have to do any more PET CTs until we saw a positive,
Yeah, and I think in some areas we're moving towards that. There are trials in like colorectal where they're actually using ctDNA status to like guide de-escalation of therapy or things like that. So yes, I think that there is probably a future world in which that's a reasonable approach, but we got a little more work to do. It would be my take on it.
Great. Well, thank you very much.
Roger's from UCLA, lab-based dermatologist. Thank you, Roger.
Thank you, Kim. Thank you, Rick, for this invitation to speak. So this topic is quite broad. I'm going to focus on what we do in my laboratory at UCLA, which is cancer evolution, focus on therapies as the selective pressure, but I'm also going to talk a little bit toward the end about metastatic progression from primary tumors. Here are my disclosures. Only relevant ones are current day one, Beijing. So I'm going to sort of pose a series of questions which my laboratory has been focused on over the past 10, 15 years, and then sort of give you a very brief answer to these big fundamental questions. We heard about targeted therapy this morning, immune checkpoint blockade therapies. Of course, whenever you impose selective pressure, cancer evolves depending on the genomic instability status and heterogeneity. So the first question we ask is, what is the most important mechanism of relapse on targeted therapy? Obviously, MAP kinase targeted therapy. So this is one of our earliest studies where we try to dive into this question. The favorite place to start is by looking at samples, tissues from patients. Here we acquire patients' tissues, melanoma before therapy, before BRAF inhibitor therapy, and then after the response period, that median progression-free survival is 7 months, we then pick up more biopsies when the disease progresses and the patient relapses on therapy. And so the answer to this initial study was that we needed a BRAF inhibitor combined with a MEK inhibitor. And that was the proposed translational message of the study. The mechanism underlying that proposal is sort of schematized here. As you know, the current BRAF inhibitors that we use are not these pan-RAF inhibitors. They're these monomer-specific inhibitors or monomeric RAF inhibitors, bevacizumab included. And this is really the reason why we have the therapeutic window that we have with the BRAF inhibitors that we have when combined with the MEK inhibitor. That's because it's monomer specific, and BRAF V600E mutation basically alters the functions of RAF, so that is now a single molecule activating the MAP kinase pathway, in this cascade of MEK activating ERK, turning on this oncogenic pathway. However, in relapsing patients where the tumors acquired a disease progression, what we see are different genetic configurations. What I show here in the middle is a very unusual genetic configuration where the BRAF V600 mutation coexists in a clonal level with with an NRAS mutation. So these are known to be mutually exclusive alterations, which in the context of relapse is now coexisting. So that has obviously signaling impacts, and the way we dissected this genetic alteration is by looking downstream in the pathway. It turns out in the context of dual mutations in BRAF and NRAS, the monomeric signaling of BRAF turns into a dimer signaling entity again. So now the MAP kinase pathway is driven by dimers, so that renders the BRAF inhibitor ineffective. And so the approach we proposed was adding on a MEK inhibitor to the BRAF inhibitor, and the MEK inhibitor at the time was being developed as a monotherapy for melanoma. So as we learn to understand this resistance pathway further, all other mutations also converge on this reactivation phenotype. Where we end up studying were the patients who are now being treated with BRAF plus MEK inhibitors and then relapsing on that therapy, although at a much lower rate. And what we found was actually very surprising. We thought the first instinct was that some other pathway must have been turned on when the cancer relapses. But as it turns out, the majority of the time, the MAP kinase pathway is reactivated again. So the same theme, reactivation of the pathway you're trying to target. And now, instead of point mutations, you're seeing copy number alterations. Copy number alterations in a gain direction that increases protein productions, that accentuates this type of dimerization. There are also mutations in the downstream protein MEK, which allows for, so as you know from the existing literature, RAF interactions sort of interact in this face-to-face manner, and the BRAF MEK mutations interact in this back-to-back fashion. So the mutations in MEK would then render that back-to-back interaction more potent, thereby turning on the pathway again in the face of both BRAF and MEK inhibitors. So this is obviously a very daunting question. So let me just revisit the initial question: what is the most important mechanism of acquired resistance? We would claim that this is MAP kinase pathway reactivation. This is shown by patients who are treated with BRAF inhibitor monotherapy, and then with combination with MEK inhibitors. So the next question for us after 5 years of studying this problem is, what is next? Should we be looking at every single mechanism that can exist in the universe and then try to target them with combinations? That seemed to us very futile. So we started thinking about, well, if the cancer has to come up with all these different mutations to escape from the drug, are we able to find a common denominator pathways to inhibit cancer evolution, meaning the process by which the genome of the cancer changes? So that leads me to the next question: can we prevent or target the roots of resistance, the very process by which the genetic alterations occur? So I'll lead you through some of the rationale behind this. This is another patient where we started this analysis where we tracked the initial response towards multifocal, multi-spatial disease progression in this particular patient, or this type of patient, over a span of time, looking at all their different mechanisms of resistance and trying to see what are the commonalities among these mechanisms. Are there signatures underlying all these disparate mutations that would tell us the genetic instability process that's underneath? So sort of schematically, this is sort of visualized here in this Darwinian phylogeny. So instead of targeting the axis, the individual branches that are mediating resistance in different tumors in the same patient sometimes, or even different mechanisms in the same tumor, what we want to do now is to see if we can now focus on the bottleneck of evolution when the persister cells, the cancers that survived the initial onslaught of the therapy, is now changing their genomic makeup. And what we found in the last 5 years has been quite illuminating. These are studies that we published in the last 3-4 years, looking at what exact genomic instability process are occurring that allows the mushrooms of different genetic mechanisms of resistance that leads to pathway reactivation. To really not show you all the details of the studies, what we found are these very dramatic changes in the genome. One of the most important processes being chromothripsis. This is a process by which the DNA of the cancer cell actually reshuffles themselves in very large spans, up to sometimes even hundreds of megabases of DNA. And these fragmented DNA can then now rejoin, creating genetic diversity, which is the fodder for natural selection. And in the process of rejoining, some of this DNA gets lost because of pathologic repair. And the lost fragments of DNA could harbor important critical tumor suppressors. But more importantly, some of these fragments never goes back into the genome and remains extrachromosomal, and they circularize into these ecDNAs. And these ecDNAs then harbor genes that could include the drivers of targeted therapy resistance. There are important targets in studying this area of science, genomic instability, as we show here in this paper that we published last year, showing that just chromothripsis alone, we are able to identify new targets, some of which do not have preclinical or clinical agents available, but we do have, in the process of religation of these chromosome fragments, religation of fragments into ecDNAs, a common process called non-homologous end joining, and there the central catalytic enzyme DNA-PK actually has clinical stage small molecules, which we think may be impactful in sort of slowing down the evolution of the cancer. So then the next question is are these genomic stability processes pre-existing or de novo? And this is the study that we undertook recently to show that much of this is actually de novo, induced by the targeted therapy. So how does that occur? So we started engaging in molecular cellular studies to look at what happens after targeted therapy exposure in PDX models or cell culture models. What we found is rediscovery of a lot of science that's been published in the last 10 years, but also some novel angles to this, which is that targeted therapy leads to persistent cells that has changed the mechanophysical properties. The cells become larger, flattened, more mesenchymal, and that imposes stress fibers that impinges on the nuclear envelope, creating these little blebs in the nuclear envelope that are sites of genomic instability, DNA damage. Then that leads to micronuclei, which then ultimately leads to these scrambled genomic fragments. And what is underlying these mechanophysical change, and that goes back to signal transduction again, the alterations that occur with blockade of the MAP kinase pathway leads to rebound signaling, including activation of the Rho-ROCK pathway, which also gives us clues as to potential targets. And one of the biggest targets in this pathway are ROCK inhibitors, which has FDA approval in non-cancer indications, ocular indications, for example. So we try that approach. We apply ROCK inhibitors during the phase of persister evolution, and we're able to show that we can decrease the mechanophysical changes, decrease the stress fibers, actin stress fibers, decrease the formation of nuclear blebs, which leads to micronuclei, the hallmarks of genomic instability, resulting in suppression of genomic diversification. On the bottom right are these single-cell whole genome analysis showing the phylogenetic patterns without a ROCK inhibitor in the presence of MAP kinase targeted therapy, essentially changing the subclonal evolutionary trajectory of the cancer. So the question that I raised before, how do we prevent acquired resistance to targeted therapy? Our claim is that by targeting inhibitor-induced genomic instability, we can make a major impact on the diversification of the cancer. So what about immune checkpoint inhibitor, an equally powerful therapy for us? Of course, we see innate resistance, we see adaptive resistance, we see acquired resistance. The kinetics of resistance in the settings are very different, tend to be so-called delay resistance. Relapse rates are different depending on monotherapy or combination PD-1, CTLA for treatment. But essentially, this does limit our survival. One of the earliest clues that we got was from this study. This is a rapid autopsy study we published in 2023, where we examined patients at autopsies and looked at their genomic profiles with respect to what type of treatments they've been exposed to before death. And what we found, highlighted a couple sentences in the abstract of this paper, was that targeted therapy, MAP kinase targeted therapy, and targeting the immune checkpoint blockade leads to very different genetic footprints, specifically in the copy number profiles of the cancer upon death. So we follow up that study with these specific clues that targeted therapy tends to favor amplification of genes, immune checkpoint blockade tend to favor expansion or selection for deletion of genes with the following study, which is just been recently accepted, about to come out probably, hopefully in the next few months, and maybe early 2026. So this is a study where we went back and then looked at samples that were collected in patients who were naive to targeted therapy or immunotherapy, and then at the time of disease progression, sometimes spaced by months to many years, collect another sample at relapse and analyze the genetic differences between the two time points. And we compare that to a wealth of data that's been published in the last 10 years, looking at different experimental models, doing CRISPR screens, for example, for all the universal genes that can modulate T cell activity, cytolytic activity. We also developed melanoma-specific models of acquired resistance to immune checkpoint blockade, either in the animal or in tissue cultures. And what we came out with was the consensus that these 4 models are telling us the same set of copy number alterations can lead to a consensus or converging phenotype of acquired resistance to immune checkpoint blockade, which is cell death evasion. And this is really not something new in immunology. You can go back to 15, 20 years to see that cell death intrinsic in the tumor cell modulate the sensitivity to attack by T cells, for example. And the proof of concept study that we performed in these studies was to show that after responding to immune checkpoint in these animal models, we impose selective pressure by sensitizing the tumor sister cells to cell death, we can actually dramatically reduce the rate of relapses. So the question, to revisit the question, does genomic instability contribute to relapses on immune checkpoint blockade therapy? Yes, and we highlight here in this study copy number variations, just as we did with targeted therapy resistance. How about adaptive resistance? Immune resistance occurs in both immune checkpoint blockade and MAPK targeted therapies. Are there critical features of resistance common to both? What we found, this is a 2022 paper, was striking similarity between the two types of therapies in that early window of therapy where you have a T-cell-rich environment, TNF-alpha, interferon gamma-rich environment, where the cells, the persistent cells, either after targeted therapy or immune checkpoint blockade therapy, undergo changes that whereby the immune resistance process upregulates tumor cell surface, PD-L1, PD-L2. And this very quick, rapid adaptation leading to more proteins of PD-L1 on the cell surface leads to immune resistance. And so the strategy in this study was then, so we know that there's an overabundance of PD-L1, PD-L2 in these treated tumor samples, and how do we then negate that process? And so the answer was to degrade that PD-L1. So this is a post-translational process. We identified a pathway whereby a E3 ligase binds to PD-L1, targets it for degradation, and then we went on to find a small molecule entity that would activate the E3 ligase ITCH, thereby degrading PD-L1 after initiating our standard of care therapies. And this is all modeled in the animal as well as syngenetic models. So the challenge here since this publication was then to make this a better drug-like molecule. Here we've been working with Stuart Conway, a medicinal chemist at UCLA. You can see on the left AK087, this is our initial discovery, has a very low potency, 80 micromolar, reducing these are Western blots for PD-L1, reducing the levels of PD-L1. As we modify rationally the molecule around AK087, we're now able to improve the potency of this molecule. So we now have a better handle on the structure-activity relationship with this compound with respect to the target it binds to. On the bottom are corroborative studies using flow cytometry measuring tumor cell surface PD-L1. You can see how there's increments in gains in the potency of this series of compounds relative to each other. So the question is there a critical feature? Yes, adaptive immune resistance, which occurs during the early window of our standard of care therapies. And this is where accumulation of PD-L1, PD-L2 occurs, and there's also a critical window for interception to degrade the PD-L1, PD-L2 on the cell surface. Last couple of slides, I'm just going to ask a couple questions that are pertaining to our recent work, unpublished work. So how do we rationally sequence and combine targeted therapy and immune checkpoint blockade therapies? This, without going into all the details of multiple studies dating back to 2015, going back between analyzing clinical data and clinical samples and experimental models, going back and forth, leading to the 2021 publication here showing that what really, when we combined them in different schedules, what gave us the most optimal anti-tumor immunity was to start with immune checkpoint blockade, followed by quick succession in combination with a targeted agent. And the last question I want to pose to this group, many of you in clinical practice, is do you know the genomic evolutionary histories of melanomas in your patients? And even patients who've never been treated with any therapy, the patients that first appear in dermatology clinics. And this is a question that sort of binds us, at least dermatologists, a lot of times when I see my patients where we really cannot explain to them what actually happened in their lifespan that gave them this disease, and we cannot predict the trajectory of the disease. I know multiple speakers at this conference have spoken about this issue of prognostication. And so our approach here is really one where we have now the technology to understand the detailed natural history of every single patient's disease, but that requires us to collect samples at different, very difficult time points, at the earliest detection of the disease at the primary stage, in a matched fashion, collect the metastases in these patients, collect the normal DNAs from these patients to complete whole genome analysis, and then to also collect the compendium of all clinical pathology data so that we can develop simple, accurate tests for prognostics and predictive scores. And this tissue set, we call the PM3, the patient-matched melanoma cohort, have, for the most part, never been exposed to any systemic therapies. So this is a treasure trove to analyze the timing of events in our individual patients. Give you one example here where we collected samples from these acromelanoma patients at 4 different time points. You can see that on the very bottom chronologic age curve. You can see the primary melanoma was taken at 69 years of age. The first metastases is 69 years old, and then the subsequent metastases at 70 and 70.1 years of age. And by doing whole genome analysis, we can use molecular clock signatures and time the relative timings of different critical genetic alterations, driver mutations, aneuploidies, mutational forces, and single base substitution signatures with copy number signatures. We can then display the full phylogeny of events, and then ultimately put them in the chronology at the very bottom. That's with respect to the time of diagnosis, either their primary disease or metastatic disease. And what's really important to note, for example, in this case, is that with both the primary and metastatic samples in our hands and the whole genome knowledge of these of the tumors, we're able to actually infer when the first cell or the first cluster cell left the primary tumor to establish some distant colony. And these are shown at the very bottom where the PM1 refers to the primary metastatic most recent common ancestor, the divergence time points. And for many patients, this dates back, not just acro patients, but this dates back decades before their primary melanoma diagnosis. In this case, at the age of 5, age of 20, age of 34. So this is really astounding and also amazing in the way that this give us, we talked about ctDNAs, does this really give us a lot of room for early diagnosis, many decades for diagnosis. Obviously, we have issues with sensitivity in the current technology, but ultimately, I agree with Matthew with whole genome deep sequencing of the plasma. Potentially, we can get to the point where we can detect very small, minute amounts of DNA being shed by these early precursor lesions that are existing in our body, potentially for many decades before the diagnostic test that shows us the patient has the disease. So finally, without taking up too much more time, I want to acknowledge my team at UCLA, some of the recent alumni from my laboratory that have since left the lab, my current collaborators listed on the right, current funding. I also want to sort of recruit potential collaborators in this audience if you're so inclined. This patient-matched primary metastatic pan-melanoma consortium is now accumulated data for over 70 patients. We want to do this at a scale, maybe hundreds of patients, and that's going to require lots of institutions, lots of different expertise to come together for this project. Thank you very much.
where you're detecting kind of or estimating that the BRAF mutation originated somewhere around the age of 4.5 years. Am I interpreting that correctly?
No, the BRAF mutation is classified as an early clonal mutation. It's not corresponding to the time on the bottom.
Okay,
The time
so
on the bottom, yeah.
No, yeah, I'm trying to understand the time on the bottom.
But by inference, not by direct calculation,
Right.
yes, you're right. The BRAF mutation would have occurred very early. It's a founder mutation.
Very early in the patient's life, way before clinical disease presentation.
That's right, yeah.
Yeah. So how do you, I guess, algorithmically, since this is all kind of via inference, account for field oncogenesis, which happen? I mean, there's p53 mutations scattered all over our bodies and our skin right now.
So field cancerization? Yeah, so that area obviously is something that we cannot touch upon, and there are recent studies showing how even epidermal cells with mutations can influence the rate of initiation. Yeah, you're right. This is not something that we can detect because those occur at single cell levels. Yeah. Yes.
Excellent, really good data. Thank you very much for some of the resistant mechanisms, summarizing them. The question that I have is understanding, PD-L1 hasn't been a great predictive prognostic marker for our therapeutic options, from CTLA-4 combination with PD-1 agents. So I'm trying to understand how degradation of PD-L1 will play a part in, kind of undoing that resistance or making it more sensitive to
Oh, that was in the context of adaptive resistance, patients who already responded to immune checkpoint, and that persistent residual tumor, you have that adaptive process going on. So not in the context of innate resistance. Yeah.
But it can get reinduced, right, along the way.
Reinduced by.
PD-L1.
Yes.
So even though it's degraded, can it just come back?
I guess it depends on how effective these PD-L1 degraders are. I mean, there are different. We've taken this approach of activating itch, but others have taken the PROTAC approach, taking unnatural E3 ligases to target PD-L1. So all different types. Also, antibody approaches that targets PD-L1 on the cell surface. That with the second arm of the antibody. Recruiting a non-physiologic E3. So both small molecule antibody approaches are ongoing, and both PROTAC approaches and our sort of molecular glue approach is also ongoing.
Any other questions? Well, thank you very much.
Thank you.
Thanks, everybody, for staying through this, my disclosures. So when, Kim and I are the organizers of this, my tendency would be talk about surgery, but Kim didn't allow me, so she said, you're going to do biomarkers. So because we all do things on AI now, I looked up what biomarkers are, and basically it's pretty much everything that you use to describe disease, prognosis, and monitoring treatment. So since Matthew already spoke about ctDNA, I thought I would try to cover all the rest of the potential biomarkers that we could use in melanoma. So the first biomarker we use is actually, our vision and analysis of skin lesions. So we all look at these skin lesions and we can kind of decide what they are based upon their physical appearance. So that's probably the simplest biomarker. Then this actually becomes more difficult as a biomarker because we think all these things are melanoma, but we can't really tell much about them, and so we try to use other tools. And so from the standpoint of the pathologists, it's probably hard to read the back. The pathology world has gone through an evolution of different melanocytic markers to try to describe melanoma and try to differentiate these melanocytic lesions from others. And so you can see the advantages and disadvantages of all the different stains that are available. Nima will probably talk a little bit about which of these stains could be used in frozen section and Mohs, but most of them are conventionally used on permanent section blocks. The markers that we've used in blood and serum, there's been a large number of different ones evaluated over the years, but these are the ones that are actually used predominantly. S100B is used in Europe. for late-stage disease, following patients. MIA, I'm not sure if anybody in the U.S. actually uses it anymore. And LDH is not really a marker to, I guess, follow in a sense, but it gives us some idea of worsening prognosis. And again, it's very non-specific because LDH obviously can be elevated in response to a variety of different things that happen to us, but also melanoma actually can make LDH. So from the standpoint of the surgeon, certainly in early stage disease throughout the years, we really haven't made much progress in being able to figure out the course of our patient. I mean, Roger Lowe is trying to tell us what's going to happen to our patient throughout his or her course. But the reality is in 2025, primary tumor thickness, ulceration, and sentinel node status is really only our reliable factors that we have. We use sentinel node to try to determine who's going to develop metastases, and despite it being a good test that we actually were all part of developing, it's not really that accurate. Most patients don't have a positive sentinel node, so we have a hard time determining which patients should undergo the procedure. And even if you have a positive sentinel node, that doesn't mean you're going to ever have anything happen to you with your melanoma. So, and this for anybody in the crowd who's never seen a sentinel node is really a simple process. You inject a dye or radiopharmaceutical to try to find the first draining nodes, gone through a number of studies. Mark Ferry's here, was part of the sentinel node MSLT2 trial that determined that if you have a positive node, you don't need any other surgery. And so there's been a lot of work over the years with sentinel node, and so we use it as a staging tool. And the question is, as a biomarker, how can we even determine which patients should have a sentinel node done? And so the Melanoma Institute of Australia wrote a paper a couple years ago. Those arrows point to the factors they created in their model. And so we actually wanted to see if we could make our own model using the MSLT1 data, and we did that, and our model was very similar to the Australians. We validated our data using the National Cancer Database, NCDB, and then we compared ours to the Australians, where they were very kind to share their model with us. And so basically we found out the tests, either one of them that is predicting if you have a positive sentinel node, the AUC, so the accuracy of the test, perfect test obviously has a AUC of 1, a bad test is 0, 0.5 is flip of a coin, and you can see that despite our best efforts using different clinical pathological features, neither us nor the Australians or anybody else has actually been able to make the ability to determine if your node's positive an accuracy of greater than like 0.7. So that's like okay test. And so then we've looked at the other question is, because most of our patients don't have a positive sentinel node, can we predict who's going to recur later? And so it's certainly at time 0 when you do the sentinel node, if it's negative, you can tell patients what their risk of recurrence is at that time, but there hasn't been a lot of work at looking at patients later on. So we wanted to look, and actually because our St. John's cancer-based melanoma database is so big and it's been accumulated for so long, we actually have follow-up to 30 years later, and so we can predict based upon this curves. The question is, the patient shows up 5 years after their sentinel node is done and it was negative, what is their risk of recurring at that date? Because obviously that's important. So we created a model, and we can tell patients, again, like 5 years after their negative sentinel node, what is their predicted risk going forward? So, we're going to move on to the liquid biopsy, which again is not just circulating tumor DNA. There's lots of different things in the blood. You can see there are circulating tumor DNA. There's other nucleic acids in the blood. There's exosomes, which can contain circulating tumor DNA and other nucleic acids and proteins. There's microembolite from the tumor, and there's something called tumor-educated platelets. And again, then you can actually look at serum proteins by themselves. So there's lots of different targets for potential utility in the blood. We chose to look at microRNA, but this kind of just, first off, is the idea of trying to use biomarkers in the recent clinical trials is been there, and people have worked really hard to try to describe markers as kind of been referred to everybody talking before me. It's really important because of the potential toxicities of therapy. If we can understand who needs to be treated and not, with the neoadjuvant treatment that we do now, again, we want to know who should be treated and who can discontinue treatment and who is never going to respond to therapy. So one of the approaches in the blood has been circulating tumor cells, and so there's a number of methodologies, and this was using magnetic beads. This was described by lots of different groups. One of the former fellows from St. John's, his name's Anthony Lucci. He wrote this paper a couple years ago looking at a different process using magnetic beads and trying to predict, recurrence of patients with positive nodes. Again, the technology is pretty good, but the utility of these tests has not been great, and so it continues to evolve. So we and others, and so in our lab, we've been looking at microRNA, and so microRNA are small nucleic acids up to 22 base pairs, and they are very stable in serum, and they are in response to, they can respond to a number of different stimuli. They can be progenes, they can be tumor suppressors. They have lots of different functions. Again, they're not just found in blood, but they're found in other body fluids. And again, they're very stable to freezing and thawing. And that we thought they would be a reasonable target to look at. Again, they're not directly related to the tumor, so they can be related to the microenvironment of the tumor. And that's what we thought would be important, because we believe that the microenvironment around the tumor is active and continues to evolve and is really important in the process of developing metastases. And identification of the microRNAs that are expressed would be an important component to determine what's happening with our patients. So again, we're not the first group to look at microRNAs. Similar to the ctDNA data, there's been a lot of different ways that people have tried to identify microRNAs. A lot of it was originally done through just bulk PCR, which is limited by sensitivity. We now do it using next generation sequencing. There's been, originally there was probably 1,000 microRNAs described. Now there's over 2,000. And so if you didn't look for the right ones, you would miss them. And so again, a lot of these different papers that I put up here describe pretty good results, but all the methodologies are different. They're mixed mash of patients, and so it really makes it hard to interpret the microRNA data. If you look at the microRNAs they saw, some of them have some clues that these actually might be related to tumor progression. A lot of these microRNAs have multiple different functions, and so it's even hard to figure out exactly from a standpoint of function, what's actually going on with the patient. So again, we decided that we were going to look at patients who at the time of surgery had a negative sentinel node. The blood was harvested at the time of surgery. We estimated that our hypothesis is the microRNAs change over time. So our concept was that we would look at the microRNAs at the time of diagnosis and just say, what is the risk of recurrence up to the first landmark, which we said was 2 years. And so we're able to create a panel from the 2,000 microRNAs that we looked at. Our 9 microRNA panel was a predictive 0.9, which is quite a good test. And so we're continuing to work with this. We add it to the clinical features. So there's the 9 microRNA. They have lots of different functions. A lot of them don't have, again, good descriptions of what they do. We went back and looked at the other papers that have been published. Some of our microRNAs overlap, some don't. Some weren't in the other papers at all. So again, they didn't look for all 2,000. And so this is kind of where we're at. We have to validate it, obviously, but the point of it is this is one clue that we might be able to use a microRNA in certainly an early stage melanoma. When we looked at advanced patients, we didn't see a signature. So we were happy that at least our initial signature, or again, it fit our hypothesis that probably in advanced stage patients, there's something different happening to them. We looked at healthy donors because we said, is this just something as a byproduct of humans? And the answer is no. And so, again, we continue to look to see, we have to validate it to see if the signature is actually worthwhile. Does the signature change over time? We think it does. And so this is kind of our comparison of what the microRNA signature looks like compared to other tests that are out there. And you can see us as surgeons, sentinel node alone, the AUC is 0.57. Again, we were able to predict the status of your sentinel node, but the sentinel node itself is not a great test, although, again, we use it all the time. So, again, this continues to evolve. And this is, again, some of the other work that's been done using other microRNA to try to look at different signatures. You can see the curves in this particular study are quite wide. This particular study has never been validated, so the field is kind of wide open. So this table is probably hard to see in the back, but you can see on the left is the giant list. Again, there's over 2,000 microRNAs that have been described, and so a number of them have been studied in melanoma. They have, again, different functions, and again, none of this work, unfortunately, has yet been validated, so that's why we don't have a microRNA in melanoma at this point. I think Dr. Hedberg alluded a little bit to exosomes. So exosomes are bodies that are essentially pinched off the cell membrane, and they basically can circulate. You can obtain them in the blood, particularly the plasma. They contain nucleic acids, they contain proteins. You can look at a number of different functions coming off the exosomes. MicroRNA are inside the exosomes too, so it's another compartment that we actually could look at. We chose, again, to look at mRNA in the serum as our target, but others have done work looking at microRNA and exosomes. Again, here's some of the studies that have been done. So again, the field is wide open, and it's quite difficult to understand because, again, the function of a lot of these microRNAs are not even known. So active studies in liquid biopsy, this was from a couple years ago. Again, I apologize, it's probably hard to read in the back, but this was a number of different studies that are trying to be concurrent with ongoing clinical therapy trials. Again, the importance of this is that, you know, a number of different groups continue or try to investigate potential options for biomarkers because of the importance in following our patients and their treatments. So another biomarker actually is taking a step back is, you know, making early diagnosis. And so here's an example of some of the apps that are available on your phone to try to figure out if you have skin cancer. Again, so these are apps typically using AI models of an image. Their limitations are obviously the camera, the limitations of how big their data sets are. Obviously, there's no ability to detect texture or evolution of a lesion except if you have serial images. Again, these apps have been out there. Again, a lot of people are skeptical, again, because of their limitations of what I described. This is another kind of evolution in imaging. This is confocal microscopy, which uses a laser and a microscope to look at differences in cell. So basically, a mole is broken down into these number of different units, and each of these units are put together, and you can analyze skin lesions using confocal microscopy to make diagnoses and potentially margins of excision. Digital pathology is an evolving field. The only mention to say this is, again, it's a continuation of kind of our evolution of pathology and to aid in the pathologic diagnosis and assessment of skin lesions in this particular case. Somehow the Outlook thing popped up, David. And so this is just example of kind of the data that's obtained and how they can discriminate, say, a benign skin lesion from a malignant skin lesion using AI analysis of these images. And so, for example, for us, we want to be able to tell a difference between a skin, a melanoma that's going to metastasize versus one that's not. Groups have tried to determine if you can, look at a skin lesion and actually tell if it has a BRAF mutation or NRAS mutation or wild type without having to do any kind of molecular analysis or staining. And then certainly, again, another tool that has actually kind of come and gone. This was a company called Dermtech, and they basically had a little tape, and you'd put it on a skin lesion, and then it would look for a particular gene profile. And the idea was good. The derms, I don't think, particularly liked it. And like I said, the company has come and gone, but the idea of being able to make a non-invasive diagnosis is certainly intriguing. And then certainly, this is some of our data looking at primary and metastatic melanomas, and looking at molecular gene profiling. You can tell the difference between the primaries and the mets. At this point, useful in the sense from the research, but not really come to help us much. Being able to tell that patients would have metastatic lesions do worse is not anything new, but the idea of being able to tell which treatment pathway a patient should go through is probably more intriguing. And so this is some of the work that's been done by other groups looking at different molecular profiling of primary tumors. One of the difficulties, certainly in melanoma, is the tumors are small, and it makes it hard to get access to even paraffin tissue. And then certainly this is some of the work that we did. We identified this gene, CXCL1. It's a chemokine. It's expressed in the microenvironment of melanoma, and certainly its overexpression relates to poor outcome in melanoma patients. And so, again, this and others have been shown to, again, be potential biomarkers in melanoma. And again, this is just work from other groups, again, looking at different signatures. Again, unfortunately, none of it has been validated in the sense it's ready for prime time use. And then again, I think Dr. Hedberg kind of referred to it, is that, we're doing a lot of gene expression profiling and next generation sequencing. This is some of the next generation sequencing from one of the companies, but the point of it is we look at lots of different genes in melanoma, and there's actually just very few that we know that are clinically relevant at this point. Hopefully one day with continued evolution of our understanding, that will certainly have a better role for trying to use these giant databases that we get back from the next generation sequencing. So again, this continues to evolve, and so we shall see in the future exactly what's the role of biomarkers, and can we make it better in melanoma. So thanks everybody for your time. Any questions? Go ahead, Kim.
Yeah, I'll ask you a tough one. This will be the Jeff Sossman question. Do you think there will ever be a time when we'll have some kind of a composite test that reflects, in particular for immunotherapy, but maybe even for molecularly targeted, that will encompass multiple types of biomarkers and reflect, a sort of the whole car engine instead of just one or two components that could easily be changed in response to pushing the system with a therapeutic intervention?
Well, I think it's slowly evolving into that now, that there's, different groups are approaching it like from different angles. And I think kind of what Roger said is, I think what everybody's kind of thinking, like, how can we understand the course of the disease from beginning, and so that we can predict like a particular patient's outcome and which treatment pathway. So, but I think it's multiple elements, right? Okay, well, thanks everybody.
While we're setting up, just a special thanks to Rick and Kim for the invitation to be here today. It's really, melanoma is obviously a multidisciplinary disease, and it's really nice to be in a group that approaches it in different ways and to learn from all of you. Just as a quick background, I'm not even sure if, Rick, if you know this, but the reason I started doing Mohs for melanoma about 10 years ago was because of some of our conversations at Tumor Board while you were at Cedars. So thank you. I'm going to talk about Mohs surgery for management of cutaneous melanomas. These are my disclosures. So the primary thing that we're going to talk about in terms of why we choose to do Mohs for certain melanomas is basically related to, this old picture of what defines sort of accuracy versus precision. The goal is basically to be as accurate as possible, to be as precise as possible, by examining 100% of the margins in real time. That way we can maximize tumor clearance while sparing healthy tissue. So in order to kind of understand what the role of Mohs is for melanoma, we'll talk about Mohs surgery for non-melanoma skin cancer first. So this is now, it's considered the gold standard, especially for skin cancers that are on cosmetically sensitive areas like the head and neck, especially those that have ill-defined clinical margins and those that in a background of chronic sun exposure. So I don't know if you guys are familiar with Mohs, but traditional surgical excision involves bread loafing, where certain margins can get missed. So if you look at actually what percent of margins are examined when a pathologist looks at it based on traditional bread loafing, it's about 1% of peripheral and deep margins examined. And so any report you see from a pathologist typically says margins appear clear because they haven't looked at every single margin, just the margins they've looked at. With Mohs, it's sort of cut at a transection. So when you're looking at it, you get 100% of the circumference plus the depth. So in that sense, it's less likely to miss some of the cancer. The downside of Mohs surgery is that you don't get to know what the depth of a lesion is, because obviously you're cutting it at a transection. So if you're doing invasive melanoma and you care about Breslow, you probably want to do some sort of a debulking specimen or consider doing a standard or wide local excision. So the goal with Mohs is precision, and ideally this results in tissue sparing. It doesn't necessarily mean that we're always taking teeny tiny little bits of skin and trying to preserve cosmetics as much as possible while leaving skin cancer behind. It's basically about precision, and this oftentimes results in a low recurrence rate. It's about 1% to 2% for non-melanoma skin cancer. The nice thing about it is path and reconstruction are done on the same day, so patients leave knowing that their cancer is out and hopefully getting good cosmetic outcome from their reconstruction. In a sense, most surgeons, at least those who do a lot of reconstruction, you're trained in some plastic surgery techniques as well. And over the years, the American College of Mohs Surgery and the American Society for Dermatologic Surgery have come out with these appropriate use criteria, so we don't overuse Mohs. And primarily, what we try to serve Mohs for is using it in areas that are considered high risk or medium risk. So head, neck, face, genitalia, hands, feet, and maybe the shins. So I'll just show you some examples of Mohs for non-melanoma skin cancer. These are just sort of like before and afters. Again, the advantage of this procedure for non-melanoma is you can do it for cosmetically sensitive areas like the nasal tip. You get path the same day. So this patient comes in at 8 a.m. Usually by like 9, 9:30, 10 a.m. they're clear. And by 10:30, 11 o'clock, we've done the recon and they're out the door. And this is probably about a 1 to 2 month outcome right here. A bigger lesion on the nasal tip, on the left nasal tip. Similarly, this one required a trilobe flap, younger patient, but at 3 months, a good cosmetic outcome. A much older patient. These patients usually result in the best cosmetic outcomes because they just have a lot of lines and a lot of areas where you can hide things. So again, this one required sort of a multi-step approach, using a crescentic advancement flap and then using a Burroughs graft to recreate that little soft triangle between near the nasal crease, and a good result at 3 months. And then another basal cell carcinoma. This was very challenging. It was multi-unit, wrapped around the eye. Ended up repairing him using a Mercedes advancement flap with 2 skin grafts, and the outcomes were so good that we published it in Derm Surg in 2022. Okay, so let's move on to what you guys actually care about, which is melanoma. So the evolution of margins, we actually wrote a sort of like an editorial or review paper a couple years back. My former fellow, Dr. Rosenthal, wrote it. It was called From Centimeters to Millimeters, the Evolution of Surgical Margins for Melanoma. And I borrowed this slide from Dr. Ferry's, which basically just shows, the history of melanoma and how we were taking these massive margins pre-1970s, including the 5 centimeter margin that Hadley had published. And then if you look at what current melanoma guidelines are, whether you're looking at the UK, the US, Australia, or even the AAD, what the AAD has to say. For in situ, it's roughly about a 5 to 10 millimeter margin. For anything less than 1 millimeter, it's a 1 centimeter margin. And above that, it's probably a little greater than a 1 centimeter margin. And I would say this is one of those things where probably over time we're going to see trials. I think you guys are working on a trial where you're looking at margins for invasive melanomas as well. So how does Mohs micrographic surgery fit in for melanoma? So the clinical scenarios here are looking at lentigo maligna or MIS or early invasive melanomas, T1As, that are in cosmetically sensitive areas, nasal tip, somewhere on the face. Those that have ill-defined clinical margins where it's really hard to know where, without doing maybe some scouting biopsies, where to take your first margin. Especially in the background of chronic sun exposure. Again, the goal here is precision. It's not taking teeny tiny pieces. And then we talked about some of the other stuff regarding to path and recon. Again, just like for non-melanoma skin cancer, there's appropriate use criteria here where we typically use this procedure for areas that are in area H and M, which are those high risk or medium risk areas like the face, the neck, and so forth. The difference between Mohs for melanoma and Mohs for non-melanoma skin cancer is there's additional steps. So for this, you want to use positive and negative controls, and almost always you want to send a debulking specimen. And this can be done frozen or paraffin embedded. When we do a debulking specimen, we almost always send it to path just to make sure that if we're treating an MIS, it's truly an MIS, or if it's an early invasive, that the depth hasn't changed, the Breslow depth hasn't changed. At the end, you could consider taking an insurance layer. It's rare that I do that now just because we've had so much experience with it that I feel comfortable with our margins. And then the most important thing is you want to use immunostains. Rick talked about a number of stains that are available, including SOX10, PRAME, MART1, and some others. The best one, at least the one that's been used most frequently for Mohs, is MART1. So the other ones, I feel like with frozen sectioning, it's sort of still experimental and we don't use it as often. So I'm going to show you a slide here. So there's 3 H&Es here. These are all frozen sections. So how many of you guys, which one of you guys think is the melanoma? A, B, or C? This is just to highlight that it's so hard to know what's going on. So maybe in C, you can see some nests and some bridging. In B and A, it's almost impossible. But if you actually look at the MART, you'll see that all 3 of them are melanoma in situ. So that's where the advantage of staining comes in. And I think this procedure has changed and improved over the years as the staining quality has improved over the years, as companies have come out with better staining. The downside is when we do these procedures, from a clinical standpoint, they take a long time. A typical Mohs layer, if I cut it for non-melanoma skin cancer, I'll get slides back in about 20 minutes. For melanoma in situ, because of the immunostains, it takes about an hour. So it makes it difficult to do more than 1 case per day just because of that, just because I want to go home by 5. So, all right, so let's look at some of the data, and mainly these are the questions we're asking. What does the NCCN have to say about Mohs for melanoma? Is tissue sparing the goal? What are the margins needed to actually clear? Is it accurate relative to formalin-embedded, paraffin-embedded sectioning? What is the efficacy or recurrence rate? And does this actually impact survival? So the first thing is the NCCN. What does the NCCN say? So in one of the latest versions, they basically say the following. So I'm not going to read it. I'll just summarize it. Basically, if Mohs is performed, they think that permanent sectioning of the debulking specimen should be performed. They don't recommend it for treatment of invasive melanomas when standard clinical margins can be obtained, but it may be considered in that second line for minimally invasive melanomas in anatomically constrained areas like the face, ears, acral areas. So that's sort of how we use it. And then they say basically with respect to disease-related outcomes, there's no prospective comparisons of Mohs versus wide local excision or other methods. So that's the NCCN's thoughts. So how does this, margins when we look at it? Is it tissue sparing? Are we taking smaller margins that you would get by doing a standard excision? And the answer is actually no. If you look at all these different studies that have been published, so for example, BRCA published 625 cases of melanomas, 53% were MIS, and to achieve tumor-free plane in 99% of patients, you needed a 9 millimeter margin. Zella showed an 8.3 millimeter margin for MIS of the head and neck. Bub, similarly, something popped up, sorry. Yes, okay. So all these basically show that a margin greater than 5 millimeters is needed to clear MIS. And in our cohort of about 190 patients, we've found that the median margin to clear MIS on the head and neck is about 8 millimeters, and that's something that Dr. Marston, my fellow back there, is hopefully going to publish soon. Okay, so the goal is not tissue sparing, it's actually showing that bigger margins are required for MIS. The goal is precise assessment of margins. So what about accuracy and concordance? Here we're saying if I see it under the microscope as being clear, does the pathologist actually agree with me if they did standard, formalin-based embedded sectioning? And so we actually published a paper on this where the way to do this is you either send your last layer of Mohs, you thaw it out, you put it in formalin, and you send it for paraffin embedded sectioning, or you take an extra piece around it by like maybe 1 millimeter or 2 and send that in. And what we found is that there was about a 97% concordance between when we thought it was clear and what the pathologist in our hospital thought it was clear. This was a study we did with Oregon Health Sciences. Similarly, Brett Coldiron and his group showed about a 95% concordance in 167 patients. The next question was recurrence rates. So this is sort of a tough thing. I don't like comparing apples to oranges because sometimes our decision to do Mohs versus wide local excision for MIS depends on other confounding variables. But across the board, if you look at some of the studies that are out there for wide local excision for MIS, the recurrence rate is somewhere around maybe, you would say, 5 to 10%. With Mohs, and this has been shown repeatedly over and over, the recurrence rate for MIS is somewhere around probably about 1% or so, 1 to 2%. In fact, in our study, what we found is the patients that we've treated, about 133 of them with a mean follow-up of about 60 months, our recurrence rate was actually 0.75. And the last thing was survival data. So does it matter, are we actually impacting survival? And there's a bunch of papers that are out there trying to compare Mohs micrographic surgery to wide local excision and looking at survival. And the data on this is just unclear. There's probably some advantage of, again, doing it for head and neck. But again, I can't say that what we're doing is actually impacting survival more than what any surgical oncologist would do. So I'm going to show you just a few examples of some of our cases, and then I'll end with just some final thoughts. So this was a patient came in with a melanoma in situ on his left cheek, kind of very close to the lower lid. You can see the preoperative margin was about 10 by 18 millimeters. Postoperatively, it required a greater than 5 millimeter margin to clear. What's nice is, after 3 hours of Mohs, we cleared him. We did a rotation flap that same day, and here's his outcome about a month and a half later. I've actually followed him, since then, and no evidence of recurrence. Similar patient, sorry, skip one. Similar patient on the cheek. Again, you can see the asymmetric growth, especially on the upper portion of the margin. Repaired him using an advancement flap and a Burroughs graft, and a good result at 2 months. This was a more challenging one. I mean, I just think, this is a good example of where Mohs comes in. If you try to do this probably using, wide local excision, you probably would have to take some of the muscle out. The advantage of Mohs is you can kind of take them as thin layers, get clear margins. We repaired her using a mucosal advancement flap and a good result at probably a couple of months out. And then this is the one that sort of kind of got me thinking about what are we actually really doing. So this was a patient that came in with this, you can see this small little 6 by 10 millimeter lesion on her cheek. So we started doing Mohs. She came in at 8 a.m. 2 p.m., she was still positive. We went 6 stages. The defect was about 4 by 5 centimeters, 5.5 centimeters. So at this point, I was wondering if I'm just overreading these things and I'm just cutting out normal skin. So I stopped, sent permanents on all the stuff that I had sent out. They all came back positive, basically completely diffusely around the whole thing. So we brought her back, took an extra, couple of layers, finally cleared her the next day, and then she went on to UCLA and had a cervical facial rotation flap and a skin graft and had a pretty decent outcome. So this kind of made me think, what are we really doing here? And the question is, does lentigo malignant MIS, or any MIS, does it actually progress to melanoma, Or are we just cutting patients for the sake of cutting patients because we don't really want to leave things behind? So the answer, I mean, we don't know. No one's going to do that study where you're going to leave MIS and say, I want to see what happens in 5 years or in 10 years. So most of us end up cutting it out or treating it in one way or another. So it's a difficult thing to measure. What we do know is that if you look at recurrent MISs, about 22% of them had an invasive component. So again, is it the chicken or the egg? Was there recurrence that was missed, or did it recur and then gain some access to, a deeper portion? The thing that's important is, always making sure that we do a debulking, like I mentioned. We published this paper a couple years back also, or a year back, where we looked at upstaging of cutaneous melanomas after Mohs and looking at the debulking specimen. We found that about 2% of our specimens were upstaged with a debulking specimen. In some other studies, it's been as high as 20%. And again, this can be done using frozen or permanent sectioning. So last slide, just some final thoughts. I didn't really get into this, but a lot of times at these tumor boards, we have these recurrent cases, and people say, okay, what about using topicals? The agents that we have available are imiquimod, 5-FU, and sometimes we use them with calcipotriene because it allows for better penetration. The data is so mixed on this. It's probably about a 30 to 70% recurrence rate. There is no long-term data on any of this stuff. And in a way, if you think about it, the way we'd love for these topicals to work is they take a lesion that's maybe this big, and they just slowly shrink it and shrink it. But that's not what happens. They clear a little bit here, a little bit here, a little bit here, a little bit here, a little bit here. So you get this sort of like asymmetric clearance, and then when there's a recurrence, you don't even know where to start because the recurrence is sort of like in multiple areas. So it makes it much harder to treat surgically. That being said, I think for patients who have field defects and recurrent MISs, this is probably the best thing you can do for them. Because the other sense is if you have somebody like I have this lady who's had a recurrent MIS 5 times, she's 5 to 10 years out now from her first one. That disease has already defined itself. It's never going to kill her. It's been 5 to 10 years. It's always in situ. So we just basically treat her with liquid nitrogen now, a little bit of topicals, and then every time she comes in, if I see a brown spot, I'll just treat it a little bit. And every couple of years, if she wants for me to do a biopsy just to prove that it's nothing invasive, we'll do a biopsy. So I think that's where topicals might come in. The last thing is there's a lot of stuff about gene expression profiling and microRNAs. In dermatology, we actually do use gene expression profiling because I feel like it helps us guide our decision for sentinel node biopsy in some of the older patients. The main thing it does for us in derm is it adjusts our surveillance strategies. If they're low grade or like a low class, or low risk, we might see them less frequently, and if they're high risk, we'll see them more frequently. But more data is needed in this. But as far as Mohs goes, in summary, we think it's a good option for melanoma in situ and early invasive melanomas, especially in cosmetically sensitive areas or in the background of significant sun damage. So thank you for your time. Happy to answer any questions. Yes, please.
Why is it in the background of chronic sun damage? Just because of the field effect?
Well, so I think what ends up happening is when you have a lot of sun damage, it's hard to know where to take your original margin. So there's two approaches to that. You can certainly do scouting biopsies. If your scouting biopsies show that it's one area is clear versus another area, where one area is just lentiginous changes, then you can do wide local around the area that you find positive. The other option is just do Mohs and maybe use a Woods lamp or something to kind of guide where you start with, or start smaller and then just see where the pathology takes you. Please.
I know you can't really answer this, but are there any promising molecular or other biological approaches to understanding which MISs are going to become invasive so that time isn't the only risk factor for the aggressiveness that we have to take to treating melanoma in situ?
Short answer is no. I mean, as far as I know, also even some of these prognostic ones, you can't do them on MIS. It's always invasive melanomas that you're doing it on. Probably one area where we might see some improvement is the way PATH is done. I mean, there's some data that if you see extensive pagetoid, if you see extensive bridging of nests, that those are the ones that are more likely to either be recurrent or possibly even have an invasive component. But I think you need more data on that. So, and I'm assuming with improvements in AI, especially as it relates to PATH, we'll probably have some more information in the future. Thank you all.
Dr. Gharavi. The next speaker will be Dr. Vivian Wu, who's a relatively recent recruit in head and neck surgical oncology to St. John's.
I want to say thank you to Kim and Rick. This was really an illustrious panel of speakers. I've learned so much today. So our overview today will be some epidemiology, which really nobody has necessarily gone over, and I'm going to pull some stuff that I Googled, but I think it's interesting information. And then I'm also going to talk about SCC today because it's a huge part of the head and neck practice, certainly, of course, melanomas, but we'll get to that in a little bit. And then some surgical considerations about resecting primary site, regional disease, reconstruction, and neoadjuvant treatment. A lot of that's been discussed today, and I will say I think I'm in a room full of people trying to put me out of business, and I'm okay with that. You know, there's still more surgery to do, but someday I think we may be a secondary in this disease. So this is an old slide, but it's one that really just kind of tells you about sort of incidence worldwide. I like to start worldwide and see, you know, you can tell worldwide that this is obviously a disease of first world countries, sort of Anglo, people of Anglo descent maybe, you know. But really I wanted to show you that slide on the right showing Australia and how terrible their rates are. If you look at that actually ends in year 2000. You probably can't see it, but it ends in year 2000, and their incidence rate at that time was 50. Currently they're at 70, which it's just the rapid rate of melanoma there. But how about the United States? We are at about, you know, all comers I think are like 20, 25. Please correct me if anybody else knows. But these are our numbers, and this is from the CDC. I think melanoma is not a controversial topic, so I can believe this data. But California, you know, is doing not great, but also not as bad as the Pacific Northwest, which again, why, if anybody has theories here, I'd love to hear them. Utah, I feel like it's the skiers, and Vermont and New Hampshire, but Colorado looks okay too. So, I mean, not okay, but, you know, better than some, and I don't really understand Texas there, but. Let's go to California now. Okay, I am new to California, so I don't really know the counties that well, but I did focus a little of my just review on Southern California. And the red there is Santa Barbara County, and then there's there's a yellow patch, which I don't know what county that is, but then there's the orange, which is Ventura. And LA is actually not bad. We're like the lowest incidence, and in fact, if you look at the CDC website, we're doing better from last year from a melanoma standpoint. So this is great news. Then you've got Orange County doing not so great in orange, and San Diego County down below. And then again, Northern California with lots of red. Not sure what's going on there, but okay. Switch gears just a little bit. Let's go to cutaneous squamous cell. So we don't have great information on numbers for cutaneous squamous cell. As many of you know, we track melanoma registry numbers, but there's no registry for squamous cell carcinoma, okay? So this data comes from a group in China. They've been just taking math and like just running the numbers from this global burden of disease website, which I don't know how real the data is, okay? But that being said, I still think that their pictures are telling. The top is incidence of cutaneous squamous cell, the middle is deaths, and the bottom is it's dailies, which are disabilities, basically how much loss of sort of, how do you guys describe this? Dailies are, you know, you lose adult productive lives. Essentially, how much do you lose because you are treating or dealing with a squamous cell carcinoma? Sorry, that was not that clear, but you probably all know what dailies are. So again, you know, focusing, if you look at the top, the incidence of cutaneous squams, the United States, Canada not doing great, and Australia not either. But what they really concluded was in the next 25 years, everything is going to rise, like astronomically, to be honest, which is not good news. Okay, and then why, as a head and neck surgeon, right, do we necessarily care about cutaneous squamous cells? The photo or the graphic that I pulled just from the internet shows that in men, and this is all comers for skin cancers, that in men, about 30% of cancers show up on the head and neck. In women, only about 17%. But, and I don't know if I believe this number, I did read somewhere, 85% of cutaneous squamous cells are found on the head and neck, which to me is really an astronomical number, but I guess believable. We just don't have a registry to know. So this is where I'd love to get real good data on this. So this is sort of, I'm just going to start into the surgery stuff of things. This is sort of a concept that I stole without permission from my buddy TJ Au. He just gave this sort of View Medi talk, but I like the way he broke it down, which is when you're thinking about surgical considerations of skin cancers and head and neck, you want to think about, it sort of 4 different ways. Is it technically resectable, right? This is the sort of story of surgeons saying, well, we can resect anything, but should you, right? And so things like, is the carotid encased? Is your skull base invased? So skull base is an area at the bottom of the skull where all your cranial nerves come out of the brain and then into your neck area. So is there skull base invasion? Are those cranial nerves involved? Is the paravertebral musculature invaded? Is there intracranial invasion? So these are all things like, if these are happening, you really shouldn't be trying to resect these things. But then there's maybe the more important part, which is the functional resectability. And our last speaker, sorry, he discussed some of this, right? Like, if there's orbital invasion, do you have to take the eye? If the facial nerve is involved, is your face, having sort of a stroke-like look to your face, that's terrible. Cranial invasion we talked about, but also the eyelids, right? You don't have a lot of skin at the eyelids. You can't just sort of patch it up with some skin grafts. So these are all considerations when it comes to, taking out skin cancers of the head and neck. And finally, lips. You saw that a beautiful example earlier. And then, of course, cosmetic unresectability or resectability, if you have to take an entire nose, if you have to take an entire ear, or again, parts of the face. And then finally, medical unresectability. So I see a fair number of patients in their 90s. Should we be doing surgery on these folks? Age is, we're no longer looking at age, we're really looking at the concept of frailty. And are these patients able to go through an operation or a procedure without resulting in significant comorbidities. And then, of course, finally, comorbidities. So here's just, one of my patients from quite a while ago, 68-year-old, he had a 6-month growth of this thing. He was referred to plastics, who did a beautiful biopsy and put like 5 stitches in this very small region, but they do a good job closing. And so, the specimen came out like this. And this is nothing terribly interesting, but I just want to point out tumor thickness, which is, again, what we go on, like, okay, it's a 2.4 millimeter lesion, which puts it at intermediate thickness. You've got a mitotic rate of 15. We should probably be doing a wide local excision or Mohs, depending on, what your beliefs are, but wide local excision with a sentinel lymph node biopsy. Again, Dr. Essner earlier had shown some examples of that. And then I generally do a staged reconstruction. I agree that doing Mohs and being able to clear it and close everything at the same time is great, but for me, on the head and neck, I'm not going to be moving tissue around the same day without knowing that I'm very, very clear, and that's going to be up to my surgical pathologist to clear that for me. Again, our previous speaker did talk about sort of these margins, and these margins are ancient. We've been using them for a long time. I do wish that somebody would come up with some better numbers, but it's that half a centimeter, 1 centimeter, 2 centimeter margins. That's just kind of what we go on. And so you can imagine in this case, again, we're talking about functional resectability. This guy, I cheated a little as you got up to the eyelid, because I'm not going to be taking that rim of the eyelid. I'm going to go as close as I can and leave that, but that's not even a centimeter at that point. I could go much more inferiorly from the lesion. So staged reconstruction, I just pulled this paper. So you can see just the picture on the right. It's pretty obvious in a discrete lesion. I still wait on these for reconstruction. And the reason is, and this is just one paper of a few that I read, this is out of UVA. They looked at 600 some patients, and they looked at many things, depth of invasion, size of the lesion, subtype, location, and they basically said none of that predicted whether or not you're gonna have a positive margin at the end of your resection. And so for me, I just have to talk to the patient, let them understand that it's gonna be a 2-stage procedure. I will put that little bolster on, and none of them really complain about it, and then they know that we're going to do your sentinel, your wide local, your sentinel node, and a week later you're going to come back for surgery with my plastic surgeon. And of course, let's say the sentinel node was positive. We all kind of know this is sort of now historic, okay? We all know about MSLT2, and I'm going to take the next segment of my talk. Let me just see where for timing to sort of do a little bit of history stuff, but also to explain why when we talk about the head and neck and lymph node dissection, what's a little bit different about it. It's not that different, okay, but we like to always be special, so I'll say it's a little bit different, okay. MSLT2, we know immediate completion lymph node dissection increased the rate of regional disease control, but did not increase melanoma-specific survival. So really, the this game-changing, this landmark paper really had us move from doing completion neck dissections or completion lymph node dissections to really not doing them at all, sending them off to the medical oncologist maybe and getting immunotherapy or all the things that we've talked about today. Again, I'm about to dive into some historic stuff only because I really sort of love the discourse that happened after this paper. Dr. Ferries, thank you for sitting there without a smile on your face. But, I will tell you that when this paper came out, I did not immediately switch to not doing neck dissections. I was still completing them on majority of my patients. And it probably took maybe about 2 or 3 years to really be practice changing for me. And one of the reasons is it's just really controversial. This is just a comment on the MSLT2 about whether or not you should be doing the lymph node biopsy, and I just love this. If this aggregate of data is insufficient to extinguish the enthusiasm for immediate completion lymph node dissection, then it's unclear what more is required. So it's just people were very passionate about whether or not you should be doing the lymph node dissection or not, okay? But then you've got sort of the counter arguments, which there was so many counter arguments back and forth about what you should be doing. And so the results of this trial should not be blindly extrapolated, right? So just a lot of discourse about it. Now again, we've had all the things that we've talked about this morning. This is old news and not important anymore, but again, I'm using it to demonstrate sort of why is the head and neck a little different and why did I continue my practice for a couple of years after. So probably about 2020 I changed, but so morbidity, right? We talk about morbidity of doing a neck dissection versus an axillary lymph node dissection versus an inguinal lymph node dissection. And this is probably old data as well, and maybe the numbers are a little more inflated than they should be, but complications after a neck dissection are really considered lower than maybe those of the axillary and inguinal region. I know I have many surgical oncologists out there, so please don't get too upset with me about these numbers. But and then length of stay. This is again old stuff. I do not keep my patients in for 6 days at all. One night at most after a modified radical neck dissection. Versus 9 or 14 days for the axillary and inguinal. Again, old data, but still. And then readmission rates really not much at all after a neck dissection. So the neck dissection. It certainly is, you're working around cranial nerves, you're working around the carotid artery, but it's not, the complication rate is lower than maybe some of the other lymph node dissections. Okay, head and neck melanoma is different. There's more lymphatic basins throughout the neck. There's probably 100, plus lymph nodes on both sides of the neck. And regional disease control was critical. And this is really where I kind of wanted to make sure that I did the operation, so I captured all the disease in the area that doesn't even have the chance to grow. Okay, and then this came out of Michigan. They do a lot of head and neck melanomas there, so where I trained. But I think the most important thing for me, and this is the last bullet point, that 25% of those who had completion lymphadenectomy still had one positive sentinel lymph node. And to me, anything over 20% we should probably address somehow. Again, in today, 2025, we have lots of other ways. We don't necessarily have to do a neck dissection, so I'm not doing it anymore, but I will tell you that some of these reasons are the reasons I was continuing with my practice. But it's sort of an illustration of you have this amazing paper, but it takes time to trickle out and have people actually adopt it, right? I have to be convinced that it's the right thing to do when my practice has been whatever way for 5 to 10 years. One more thing about MSLT2, and I know this is hard to see, but in terms of where the melanomas came from for this paper, only about 13% were the head and neck. So this is another thing that I used in my back pocket to say, I should be doing your lymph node dissection. Only 13% of these patients were head and neck patients, and so can I extrapolate all the data to head and neck? All right. And in fact, if you look at the numbers, I know it's small here, but those who were dissected did a little bit better than those who were observed. And then finally, okay, this is the slide. Sorry, Dr. Ferries, because he probably doesn't believe anymore. But I reached out. You reach out to people. You say, who do I know that may have more information. And so Stan Leong, who was part of the Sentinel Node Oncology Foundation, reached out to Dr. Ferries, and at the time, I think, it's hard to apply this data to the head and neck is what I got. So I said, yes, I'm doing the right thing, but again, 2 or 3 years later, changed course, right? Did what everyone else is doing now. So, okay. I'm going to switch gears now to cutaneous squamous cell, all right? And I know that this is a melanoma symposium, but again, 85% of skin cancers or cutaneous squamous cells are on the head and neck. So if you're getting a head and neck talk about skin cancers, I feel like you can't really not address this. And so, sorry again, let me just, okay. So this is just a quick graphic, right? And it comes out of Cancer 2025 of this spring. Talks about the top advancements, developments in immunotherapy in cutaneous squamous cell in the year 2023-2024. Okay, and the good news is surgery still has a role. In fact, it's still considered standard of care. Great news for me. But I think that those dotted lines, which go to either side, put them on a trial or give them cemiplimab, those are becoming more and more solid. Okay, those are actually almost nearly solid at this point. And so, it's up to us as surgeons, because we will see these patients, to decide and actually have the conversation with the patient as to, what do we think is the best way, and what's out there, what are your options, et cetera. Okay, and so, I think that this photo and those dotted lines are going to change very, very soon. I wanted to put up the guidelines. I know other people have put up the guidelines before, but this is very specific to squamous cell skin cancers. And when I trained, which is a long time ago, but even 10 years ago, I think, we maybe had low risk and high risk, and they've now actually added sort of the very high risk category, which is great news. I will say, remember we talked about there's no registry, which makes research and studying squamous cell very difficult. I feel like we should have a registry for things that are considered high risk and very high risk, because this is where we fail in cutaneous squamous cell carcinoma. But head and neck in general already puts you at high risk, okay? And so just want you to keep that in mind as we go into the next slide, which is more guidelines, but I just wanted to show you that here, high risk and very high risk cutaneous squamous cell carcinomas, this treatment planning column is sort of new from maybe the last 5 to 10 years. Multidisciplinary consultation was actually down the line. I think it was primary treatment, and then you said consider multi-D at some point in time when in previous guidelines. Okay, so this multi-D consultation early on is a new thing, not brand new, but relatively new in the world of cutaneous squam. And considering a sentinel lymph node biopsy on cases that are recurrent or with multiple high-risk features. And so really, I sort of find myself saying in our tumor boards or whatnot, hey, I'm going to do a sentinel node biopsy on a skin cancer, on a squam, and I'm not quite sure that everybody agrees with me, but I think that there's more and more evidence that we should probably be doing this. Now, Dr. Essner again did talk a little bit about the sentinel node. I just wanted to throw this in there. He showed the injection. So the next step after that injection, where you inject around the tumor site, is that you go and get a SPECT-CT or lymphoscintigraphy. Okay, lymphoscintigraphy is sort of these ink blots. You see the top row where you have an outline with like these blast zones, which is not very helpful anatomically, right? And in fact, if you look at sort of close-up pictures, it's sort of just that far right on the bottom 2 panels. I mean, it just doesn't give you any anatomic detail. So a SPECT-CT, especially for the head and neck, is very important, because I can say, okay, here's my carotid artery. You guys can't see it. You can't see it. Anyway, I could say, this is my carotid artery, this is my jugular vein, and my lymph node lives just on the other side of that, on top of my muscle, right? It just gives you a lot more anatomic detail to be quite focused in your operation and make sort of smaller incisions. I also use blue dye during this. So this was a squamous cell carcinoma, a big one, and I inject around the lesion. And why this helps is that you can actually see these. This is actually a picture from the internet. This very big incision, but it's a very good illustration of like what the blue dye looks like in that top middle photo, which helps us because we're not only using our eyes to see the blue dye, but we're using that gamma probe, which is in the middle panel under lower photo, to hear the sound of the nucleotide, radionucleotide that was injected in the patient early on. And then, of course, you take out that lymph node, you see the blue, you hear the sound, and it's great news that you've actually got it. You then put your probe back into the hole that you were just in, and if it's very quiet, you really know that you've got that lymph node, okay? And again, small incisions are really what we're going for at the end of this. And then finally, not finally, but one more surgical consideration for the head and neck that's a little bit different is the parotid gland. Okay, the parotid gland lives kind of right here in front of your ear. I was going to show a pre-incision photo too, but I forgot. But anyway, it sits here in front of the ear, and the facial nerve, which you can kind of see on that photo, it's a little dark, but the facial nerve runs like a sideways tree on the side of your face. And it does things like allow you to raise your eyebrow and do a big symmetric smile and pucker symmetrically and hold, like you puff out your cheeks, hold that air in with strength. So when you're doing a parotidectomy, you have to dissect out that nerve, okay? And the skin gets lifted, as you can see, and there's sort of like numbness there. So these are all things the patient, have to talk to the patient about for this operation. So I'm just going to use an illustrative example. Last week I saw a patient, 70-year-old man, who had a cheek Mohs about 12 months ago and developed a ipsilateral-sided lymph node that was biopsy-proven positive, okay? The PET scan shows that this is the only node positive, okay? But it was a cheek lesion which sits, and if you look at the illustration on the top, right, if you have a lesion in the blue part, you should be doing what's called a level 1 through 4 neck dissection and a parotidectomy. If you have a lesion that's in sort of like right around where the ear is, you should be doing a parotidectomy and a 1 through 5. So, there's details about what we do. But the parotid is a special area because you're dealing with the facial nerve, again, paresthesias of the face and that type of thing. So if I have a patient who had a cheek melanoma, or cheek squame, developed a node, a year later, should I be dissecting out the entire parotid gland? Right? And this is a question that I don't know. I turn to my surgical colleagues to say, would you do this when a PET scan is positive? This illustration on the bottom right is just a study out of Japan. It's like 47 patients, not really much. But they do say that there's really no connection between the parotid and the level 1. So it's, again, that sort of dotted line there. I don't actually believe them, but, maybe they're right. But I don't know if you guys would do a parotidectomy in this scenario, because it is putting the patient through more than they need to necessarily. Okay, now there's also cases like this, right? Locally advanced squamous cells, terrible, ugly, and ones in which, gosh, operating there is going to be quite highly morbid. The parotid's going to go for that top one, even for that bottom one. And so just from the guidelines, they want you to consider the top arrow there, consider neoadjuvant therapy with cemiplimab, and I think that we're really moving towards that. Again, that was actually my first slide starting this whole section on cutaneous squamous cell. This paper came out, I think, 2022, neoadjuvant cemiplimab for stage 2 through 4 cutaneous squamous cell carcinoma. That waterfall plot really shows about 68% response rate and 50% pathological response rate, which means all these patients got this immunotherapy up front, then had surgery, and then they were able to see, was there any more tumor left? And the answer is 50% of the patients had no tumor left. And these are some pictures from their paper. Of course, they're going to put in their best responses. And so, this was sort of a phase 2. They've now basically done the exact same trial. It's now out now. It is out now, NRG HN014, where it's essentially the same. You give the cemiplimab, and then the only difference, I'll tell you, is that you're still supposed to have surgery, but it's now called, quote unquote, response adaptive surgery, okay? And that is a huge question mark in the surgeon's mind. So I'm ending this with, how can surgeons still help? Okay, so we're gonna give you immunotherapy, and we may or may not still need surgery, but let me use an illustrative case here. So this is an otherwise healthy 70-year-old male, and I know, sorry, bad picture, but he had this dome-shaped crusted papule. There was an adjacent surgical scar, there was a shaved biopsy, and it came back as squamous cells. So he was referred to Mohs, and there were 2 passes with obvious bone involvement. So there's bone, the Mohs surgeon hit bone right away, and so then he was referred to us, okay? And so, he shows up in my office with this sort of cutout, and then and he's all dressed, right, with all the cotton and whatnot. But at this point is when imaging gets done. If it was done before, probably maybe the Mohs surgeon wouldn't have taken him, right? But what you can see at the top photo is that there's bone, there's a bony dehiscence, right? You can see that tumor is going into that bone. And then on the MRI, you can also see the same picture, but also a little bit of dural enhancement, the lining around the brain. And so the rest of the neck was clear, all right? But this is a big problem. Like, what do we do here? The management of this guy, and this is without any immunotherapy, okay? The management of this guy was, and I know this looks terrible, but we did a wide local excision. We actually had to take that bone, so a parasagittal craniectomy. We had to put a free flap up there, and why didn't we put so we did a staged custom craniotomy flap like 4 months later, but why didn't we put that in right away? Well, the patient had Mohs surgery, and so it's all exposed. It's no longer a sterile field, so you can't put an implant into a non-sterile field. So we had to put on the free flap to cover it, allow it to heal and clean up, and then come back later, open things up, and place that custom craniotomy flap in there to smooth out the surface. But for this guy, right? Let's say we gave him immunotherapy, okay? Like, how will we know that it's fixed the problem, right? Like, I still think I need to do a craniectomy on him because it's not like the bone's gonna grow back, right? It's not gonna, maybe the dural enhancement won't be there anymore. And so, this is, and it doesn't look like that big an area, so it's a tricky situation. And these are the ones I think that, us as surgeons, we're still here to help you despite all the fancy medical treatments that we have. But I don't know if anyone in the audience, surgeons-wise, would have done something different here. Let's say, the imaging still looks like this afterwards. If there's an injection or whatnot that we might want to try. But anyway, so responsive adaptive surgery is going to be a difficult one for us to sort of assess and understand, because for me, that last case, I would still essentially do the same surgery. So it's not like, even if I got immunotherapy and those pictures look that way, I would still need to do the same surgery. But anyway, thank you. Take questions. This is Australia's campaign, slip, slop, slap, seek, slide. They have a lot of work to do with helping their population with melanoma, but happy to take any questions.
Any questions? Go ahead, Nima.
One of the issues I find, I'm sure you agree with this, is how to surveil our high-risk patients, especially when they have clear margins. So, and they're asymptomatic. I don't know, do you guys do asymptomatic imaging, ultrasound, CTs for high-risk squames that have been cleared with surgery? Or do you just palpate their necks? I leave that up to my derm colleagues, of course. I feel like, they have all the tools that they need, like all these fancy images and whatnot. But actually, the answer is I don't think you guys have anything exactly that's that helpful either, right? Somebody needs just to create something where you can shine a light and tell us, hey, is there something concerning there? And so I do rely on my dermatology colleagues to help follow patients. If patients had a large lesion, I've done the surgery, I've done a neck dissection, I will follow those patients. But really the conversation at the end of the clinic visit, it's always like, make sure you see your dermatologist, because I don't know how to assess those as well. Thank you.
I know one of the things you brought up is sentinel node. At some point, we actually started doing sentinel node in squames, and we pretty much stopped. I don't know what John does, I don't know what Mark does. I personally found that it doesn't seem to be of any value.
And even if it's in the head and neck, your false negative rate goes up high. But I do have one comment. The last two speakers have talked about margins, and we do have a trial that finished called the MELMAR 2 trial. So that won't read out for another couple of years, but we finished accrual, and we're hoping that it will tell us that 1 centimeter is adequate for all. thickness melanomas. It was 1 versus 2 centimeters. Melmart 1 gave us an idea that it looks like it would be adequate, but we'll wait to see what that data shows.
Excellent.
Any other questions? If not, we'll move ahead to our last. Dr. Jennifer McQuade from MD Anderson is going to talk about diet and microbiome. And thanks everybody for making it through the afternoon.
Thanks for sticking around, and thank you guys for the kind invitation. So today I'll be speaking about the diet and microbiome in melanoma biology and anti-tumor immunity. So, as has been well illustrated at the symposium, the outcomes with metastatic melanoma and many other cancers have improved dramatically with the advent and approval of both immune and targeted therapy. However, outcomes are heterogeneous, right? So only about 50% of our patients benefit from our standard of care immunotherapies. With targeted therapies, that's around 90% if you get lucky and have that BRAF mutation, but then of course we have adaptive resistance. We also know that in addition to not everybody benefiting, some patients have substantial serious toxicities, immunotherapy toxicities that can become chronic and lifelong. And so why do we have the same diagnosis, same treatment, but we end up with different outcomes? And so, a lot of the field has really been focused on, this idea of what are the features that determine treatment response versus resistance. And we can look within the tumor itself. So we think about the overall mutation burden. We think about oncogenic signaling pathways. We think about the immune microenvironment. And is it a hot and inflamed tumor, or is it an immune desert? But the area that I was interested in was the one that my patients ask me about, right? If we look around the room, we're all different. And, do some of these differences in us of either things that we can't change, such as age and biological sex, but also things that we could potentially change, could these things actually impact response to treatment? And when I tell a patient that you have a 50% chance of responding, the next question out of their mouth every single time, right, is, "Doc, is there anything else that I can be doing?" And we've traditionally thought, no, right? Just kind of, take the treatment that we're giving you and hopefully it works and hopefully it doesn't. But we know from, for example, the COVID pandemic that we have different immune responses, right? We know that there are certain features such as male sex and obesity that are associated with worse outcomes with COVID, with worse responses to vaccine. And so these same things that set our overall immune tone, whether that be age or biological sex, or also things such as obesity, diet, exercise, stress, can these actually impact both systemic immunity as well as anti-tumor immunity? And one of the things that's made this really relevant is the recognition now that the gut microbiome, so those trillions of bacteria that live within us, play a critical role in setting overall systemic immune tone, and now increasingly have also been shown to impact response to immunotherapy. And of course, the microbiome is a beautiful integrator of these different environmental exposures. So again, we are more microbial than we are our own DNA. We have more microbial cells on us than we have of our own cells. And of course, the largest number of these is within the GI tract. And the microbiome had been previously studied in a number of different settings, often with autoimmune issues. And so there's an intimate and very complex relationship between the gut microbiome and the immune system. And so we have all of these bacteria. They help us digest food. They live within the GI tract, and then we have, the mucosal layer, and then right on the other side, right, we have, all of the mesenteric draining lymph nodes. And basically what we want to do is we want to tolerate the beneficial bacteria, those that are helping us break down fiber, do these other things, but we also want to not have and to be able to get rid of any potential pathogenic bacteria. And so the first study suggesting that the microbiome could impact response to immunotherapy were in mice. So this was 2 papers that were published simultaneously, one from Laurent Zipfogel's group in France and one from Tom Gajewski at University of Chicago, basically showing that in mice, which are a much simpler model organism than us and substantially less complexity in terms of their environment, but in those mice that the gut microbiome could impact response to immunotherapy. So on the left, what we see is if you take a germ-free mouse, a mouse that does not have a microbiome, they're grown in sterile environments, they will not respond to immunotherapy, the same exact immunotherapy that an SPF, so a standard pathogen-free mice will. The other paper, this is the Gajewski paper, I just think this one's so cool, right? So when we test drugs and treatments in mice, we take mice, they're the same genetic background, and then we give them melanoma, right? And then we give them treatment. And if you give them chemotherapy, it doesn't really matter where you got the mice from. But what they found, actually, is so there's 2 major facilities that provide most of the mice that we use in the US for research. One is Taconic Labs and one is Jackson Labs. And what he found is that he was taking the exact same, they should be the same mice, C57 Black 6, you're giving them the same melanoma. This is not a melanoma that's, growing up in different people. And then you give them immunotherapy. And what he found was that the Jackson Lab mice, they were uniformly responding substantially better than the Taconic Lab mice. And so he said, well, what's the difference here, right? And so, they're in different facilities. Mice eat each other's poop, so they all end up with like the same microbiome. So you kind of have a native microbiome that is specific for a facility. And so sure enough, he sequenced their microbiome and he found that the microbiomes were different. Well, so what? So then he did a fecal microbiota transplant and he took poop from the Jackson Lab mice, gave it to the Taconic Lab mice, and now their tumors responded to immunotherapy. And if you did the opposite and you gave the Jackson Lab mice the Taconic poop, they don't respond to immunotherapy. So really, really cool, right? So the microbiome can impact response to immunotherapy in mice, but how about humans? And so my colleague Jen Wargo at MD Anderson, along with Gajewski and Zipvogel, all started collecting poop from our patients as they were about to start immunotherapy. And again, 3 papers published simultaneously basically found that there were distinct microbiome signatures that correlated with an increased chance of responding to immunotherapy. So that is correlation, not causation. So now we go back into the mice. And what they did is they took poop from a human who responded to immunotherapy or from a human who did not respond to immunotherapy. Do a fecal microbiota transplant into the mouse, give the mouse a tumor, treat them with immunotherapy, and the mouse that receives the fecal microbiota transplant from the responder human now will respond to immunotherapy, and from the non-responder will not. And so this is basically telling us, 1, that the microbiome can be a biomarker, 2, that it can also be a potential therapeutic target. And so how can we actually modulate the gut microbiome to potentially enhance response to immunotherapy? And so the first is with a fecal microbiota transplant, so just like we did in mice. And here, the benefit is that you don't have to figure out what are the exact right bugs, right? You're giving everything. You're giving that whole ecosystem. But it's kind of gross. The second choice would be, instead, can we drill down to what are the specific bacteria? And is it one bacteria? Is it, kind of a clade of bacteria? But can we give the beneficial bacteria? But we have to know which ones those are. We can also, instead of giving the bacteria, we can feed the bacteria. And so a lot of these bugs that are associated with better response to immunotherapy are bacteria that play key roles in fiber fermentation. And so fiber is a prebiotic food. And finally, one area that hasn't moved forward very much, but I think is really interesting, is instead of providing the good bacteria, can we instead get rid of the bad ones. And so either by selective antibiotics or by phages. And so there's different, advantages and disadvantages for each of these. One thing with the FMT is that we have now oftentimes gone to poop pills instead of, just the kind of full colonoscopy version. The probiotics, again, we need to know which are the bacteria, and then you're introducing something into an existing ecosystem. And so if you just give one bug, or if you give a few bugs, one, do they stay, or do they get, kind of excluded out by that ecosystem? And two, do they disrupt the ecosystem, right? Is it like an invasive species? Fiber supplementation, great. Is it whole foods or actually better than a supplement? Is it the diversity of the fiber sources? And then what we know, right, is diet change is hard. We all know what we're supposed to be eating. This is the exact same diet that we're supposed to be doing to decrease our risk of cardiovascular disease and of diabetes and all these things, but we don't all do it. And so could we instead, target just some fibers, and could we have like a rationally designed prebiotic supplement? So in terms of the FMT, so these were two papers, phase 1 studies, right? So 10 to 15 patients, but they took patients whose tumors were progressing on immunotherapy. And then they did an FMT from a complete responder human donor, and then re-challenged them with the same immunotherapy that wasn't working before. And about 30% of the patients, now they start responding. And we see that we can get, good engraftment, which was kind of a question because it's not like C. diff with like this profound dysbiosis. Now, there's also been efforts to do this in treatment-naive patients, and so this was a study that had, a 65% response rate to PD-1 plus FMT, whereas usually it should be more in the order of about 40 to 45%. Now, I will say that if you look at the overall disease characteristics, this was a pretty favorable population in terms of lower LDH, lower stage, so there is an ongoing randomized study. Roxanne, can I call you out? Sure. Okay. So Mimi Wang, who is my colleague at MD Anderson, and I share a patient, Roxanne Johnson, who is a mucosal melanoma warrior. She had stage 4. She got ipi-nivo, and she had a complete response, but she also got really bad colitis. And so Mimi Wang, my GI colleague, actually did a fecal microbiota transplant from a healthy donor, cured her colitis, and now, a couple years later, her disease has recurred with slow burden. She got ipi-nivo again, has had no issues with colitis after that FMT. I had another patient who was actually on TPN for 6 months for colitis that came from another institution. And had infliximab, it had Vito, it had everything. He got 2 FMTs. Now, 3 years later, he has regained the 30 pounds that he had lost during his colitis and is back to living a normal, healthy life again, still with a complete response. So, the microbiome to me was interesting because, again, of this idea of can we modify it? So we know that the gut microbiome is largely determined by our exposures. And so mostly the things that go into our mouth. So it's only about 10 to 15% genetically determined. And instead, it's actually the things that we're eating or the medications that we end up taking. So we've known that antibiotics in multiple large studies, right, are associated, antibiotic use within the first 30 days prior to starting immunotherapy is associated with a decreased chance of response to immunotherapy. Now, again, that's correlation, not causation. Now, if you do it in mice, yeah, it also decreases responsiveness, but in humans, maybe these patients that are getting antibiotics, they were different, right? They were sicker, there was something going on. I think one of the most supportive examples of actually establishing causality is this is one of the patients at the bottom who is a patient that was on one of those FMT studies. He had really nice disease response with PD-1 plus FMT. And then what happened is he got really sick from something and ended up hospitalized and got broad spectrum antibiotics. He lost the graft and his tumor started growing again. They gave him a second FMT and the tumor started shrinking again. We also know that, lots of patients everybody wants to do everything we can to maximize that chance of response. And so people read about the microbiome and they go out to the CVS down the street and take a over-the-counter probiotic. So even when we found that 31% of our patients were actually taking over-the-counter probiotics. And those patients, even when we eliminated those that were taking it because they had had recent antibiotic exposure, they were actually a bit less likely to respond to immunotherapy. Now, again, correlation, not causation. So now we go into a mouse. We go down to the CVS, we buy 2 of the most common probiotics that are out there on the market, and we give the probiotics to the mice, and then we give them melanoma and treat them with immunotherapy. And what we see is that those probiotics actually significantly decrease the chance that they would respond to immunotherapy and basically crowded out many of the beneficial bacteria there. So caution with over-the-counter probiotics. Now, though, could we get a little bit more rational, right? Is it, the stuff that you get at the CVS, it's because, why is everything lactobacillus? Well, because it's easy to culture. It's the stuff that's easy to culture. But 90% of the bacteria that live in our gut are actually anaerobes, and ththey're difficult to culture. So we're giving people what's easy rather than necessarily what they need. And so here, Bella Glitza, one of my colleagues, and Jen Wargo, they, based on the data from our group that these fiber-fermenting firmicutes were associated with better response to immunotherapy, they had a consortia that they worked with Series Therapeutics to develop. So rationally designed consortia of the good stuff, right? And they randomized them, and they either gave them placebo antibiotic, followed by placebo consortia, this is in treatment-naive patients, or the actual consortia after they had given them vancomycin. And it was terminated early because look at that, the ones that actually got the probiotic actually had much lower response rates than what we were expecting. And one of the things may be because what we see is that after we gave them the vancomycin to try to make room in the gut for these good bacteria that we were trying to get, well, unfortunately, the microbiome never actually completely recovered. And so there was actually lower levels of the good bacteria in the end. Now, there's also, though, within renal cell carcinoma, been a study, and the first author is actually a fellow that's now working with me. So this was Ipi-Nivo versus Ipi-Nivo plus a Clostridium single strain probiotic in renal cell carcinoma. And you can see this dramatic improvement in progression-free survival here. Now, the primary endpoint of this study, and again, this was, a small study, the primary endpoint was change in the abundance of that bacteria, and they did not meet that, right? So we don't know what the mechanism is. This really needs a phase 3 study to see, is this real? But interesting. So again, these bacteria that were associated with response to immunotherapy were fiber-fermenting bacteria. And so we integrated a dietary survey assessment into our fecal collection protocols for our patients as they were starting immunotherapy. And what we found is that those patients that were habitually consuming sufficient fiber, meaning 20 grams of fiber or more, had an improved chance of responding to immunotherapy. Whoop, this Outlook thing really is persistent. So now we go back into the mouse model again. And when we do that, so it turns out that mouse chow is actually like a really beautiful source of fiber. And so instead we fiber deprive mice. So they get standard chow or they get 2% fiber. Standard chow is about 20% fiber. And now we again give the mice melanoma, treat them with immunotherapy, and what we see is that fiber deprivation significantly abrogates response to immunotherapy. Now, is it just the fiber? Oh, I've got the dreaded stuck. Is it just the fiber, or when we consume fiber, right? This is not fiber supplement. This is dietary fiber, and so they are in a package. They are in a fruit and vegetable that has, all of these other lovely phytochemicals. And so is it actually the fiber? Is it the overall dietary pattern? So multiple others have, kind of reproduced these results of a high fiber being associated with better response, but also, too, just these general dietary patterns, right? So more of a Mediterranean kind of plant-forward diet. Now, we have now that in observational cohorts that habitual diet is associated with response to immunotherapy. And in mice, we see that if we change diet, we can change response to immunotherapy. But again, mice are fairly simple. Now, can we change diet in humans, change the microbiome, and change immunotherapy response? And so because, again, diet change is hard, what we decided to do was to take out that behavioral component and do what's called a controlled feeding study, where we actually have a metabolic kitchen, and we provide patients with every calorie-containing nutrient that goes in their mouth for up to 3 months, and then collect poop longitudinally, measure their response to immunotherapy, et cetera. And so this was in 3 different settings, either adjuvant, neoadjuvant, or metastatic, and patients are randomized to a high fiber diet that actually ramps them up all the way from 30, 40 to 50 grams of fiber. Or we keep them with still a healthy diet that is whole foods, that correlates with the ACS and AICR recommendations, but we keep them where they were, which is less than 20 grams of fiber per day. And what we see is that, one, it was feasible and it was safe. So the patients ate the food. They were able to get up to 30, 40, 50 grams of fiber per day. And it was actually well tolerated. So you have some kind of initial bloating, some loose stools, but overall they were able to do this. Now, in terms of the actual microbiome change, we're not introducing anything new. We all have our existing ecosystem there. And maybe I have a particular, fiber fermenter, and maybe Dr. Ferries has, a different one, right? We're just selectively feeding those things. And so we don't see any big overall shift in the microbiome, but instead what we see is the change in the function of the microbiome, right? So they are upregulating these genes that help with fiber fermentation. And we see these really dramatic changes in conjugated primary and secondary bile acids, partially which is microbiome mediated and partially is about changing the host. Now, this trial was not powered and was not intended to look at response, right? Half of the patients were being treated in the adjuvant setting. So this is just in the patients that were treated with either neoadjuvant or metastatic setting and were evaluable for response. But what we see is actually a substantial difference in response to immunotherapy. So those that got the high fiber had a 77% chance of response versus 29% in the control. Now, it's a little too good to be true, right? It was like I got that data and I was like, I wish it looked not quite so good, because that, raises all kinds of red flags, but that's where it is. So this is under review now. The other thing that we did is now we took poop from patients that were on this trial, and we did paired poop. So we took the poop from before they started the diet intervention and then at the end of the diet intervention. And now we do a FMT and compare the effect of the diet-induced change in the microbiome from the same patient. And so here what we see is that those mice that get the post-diet FMT have improved response to immunotherapy compared to those that got the poop from the same exact donor, but before the diet intervention. So conclusion, so a high fiber diet is associated with improved response to immunotherapy. We know that we can manipulate dietary fiber in preclinical models and impact response to immunotherapy. And, early data that maybe we can do this in humans too, but again, this is a small study. We have larger studies that are currently ongoing. And of course, ultimately, we can't feed the world. This is not HelloFresh, this is a metabolic kitchen. They're really, really, really expensive. So now we have to work into how we can actually translate this into something scalable. And so with this, what we're doing now is this kind of hybrid approach where we give patients key prebiotic foods together with intensive nutritional counseling. So we're not just giving them fish, but we're actually teaching them how to fish. And I'll thank my two major partners in crime are Carrie Daniel, who's a nutritional epidemiologist that runs the Metabolic Core, and then Jen Wargo, and my lab and my funders. And thanks for having me.
Other questions? Questions?
Yeah.
So just putting in a plug for the study done by, led by Nazli Disman. She started some of that work, I think, under the
Dr.
supervision
Pant.
of Monty Paul at City of
Yeah.
Hope. And it's a single Clostridium butyricum strain. And I wonder if any of the other Hopis know anything about what the status is of that work. I know there's no
So there's a
here.
phase 3 SWOG study that's going to be starting.
Oh, okay. Thank you.
Yeah.
Does diet or manipulation of your microbiome work for other types of immunotherapies?
So like cellular therapy,
Yeah.
we don't know yet. Yep, we're
How about
collecting that.
Just any other?
So it does within, so the leukemia world has done a lot with stem cell transplant. And I was a little skeptical, those patients are so beaten up with all the antibiotics and the prolonged hospital stays. Would diet actually be important? And it turns out that in their data it is. So, and they also have some nice preclinical models too.
Other questions? Nima?
Thank you again. Great talk. I think similar to what you were pointing out to, I'm just looking at the reverse. Like we know immunosuppressed organ transplant recipients have a much higher incidence of squames and melanomas. And has anyone looked at the impact of immunosuppression pre and post transplant? Like does that change the gut microbiome in a way where it can't help with immune surveillance?
I don't know. I would imagine yes, but I'm not sure of the actual data. Yeah.
Thank you.
Are you asking the question, the people the transplant patients that get these skin tumors, their microbiome different than the ones that don't? Is that what you're asking?
Well, that could be a question too, or more just like what happens to the gut microbiome. Basically,
After.
check the poop before transplant, check the poop after transplant, and see what happens to it, and then correlate that to the ones that actually end up getting, because some of them don't get skin cancer,
Yeah.
and some do.
Yeah, and does it matter what the specific immunosuppressive that they're on?
Yeah, and the history of skin cancer obviously matters too, but I try to look it up before I asked you. ChatGPT, you couldn't find anything either.
So we're actually going to do a study, we're working on it to do with Cedars and look at the national database of actually who gets skin tumors in the solid organ transplant population and how it relates to their immunosuppression regimen.
So great talk, thanks so much, and thanks for all the pioneering work you do in this. It's always been really fascinating. One trivial question. So many of the patients that we operated on get a single dose of a first-generation cephalosporin pre-op. Is that neither here nor there? Does that have any impact?
Yeah, so Jen actually has a study where they randomize patients to not get that single dose versus where they get it. And there are some changes in the microbiome. How clinically meaningful that will be ultimately, I think certainly the dose and duration and the type of antibiotic matter, but the data is not granular enough yet. We actually have a consortium that's being funded by the CRA Foundation to get that more granular data in terms of actual antibiotics, dose, duration, timing.
And then in terms of when you have a change in the fecal microbiota, are there any blood markers that correlate with a favorable or unfavorable change, inflammatory markers, those sorts of things?
Yeah, so, so one thing is in terms of the blood is the metabolites, so kind of the, the effector arm. But there's also some so Laurence Zipvogel has done a lot of work with MADCAM1, which is basically kind of a marker of leaky gut. And she does see a change in that with, both interventions as well as a negative effect with antibiotics.
Kim?
It sounded like you mentioned that your patient, and thank you for coming, had her colitis resolved by the institution of FMT?
Mm-hmm. FMT
And-
from a healthy donor.
Yeah, so how does that work? And did it somehow, what seems to be a paradoxical effect against an IRAE, an immune-related adverse event, play into the possibility of the relapse, although we know mucosal melanoma is a bad
Yeah, I think her relapse is a couple years after the FMT, so, so who knows? But in general, so Mimi does have ongoing trials where she sees excellent response, and she's not seeing a detrimental impact on response to immunotherapy.
And then I just have another question that's kind of related to what Mark asked. I think there's a gentleman in England named Pinato who's published about a general look back, I think, about the use of antibiotics in the peri-ICB immune checkpoint blockade period with melanoma and shown a dramatically reduced favorable outcome. I don't know if he's done I think he's also done prospective. I don't know if you have any comments on that.
Yeah, there's huge meta-analyses now, showing these consistent effects. It's figuring out the confounders in those that's the challenge. There's also Bertrand Routy, who was in Laurence's lab before and is now in Canada. He also actually has a trial where they give basically like a charcoal binder, like an activated charcoal together with antibiotics, and you actually don't impact the the plasma bioavailability, but it works directly within the gut of keeping the microbiome. So I think that's the other thing is can we do some kind of protective thing? And then there's also now data too showing that that dietary fiber can help improve the restoration of the gut microbiome after antibiotics. There was a paper that was published, I think, in Nature.
Any other questions? I have one last. The skin microbiome and your sinuses, they have no effect, right?
Yeah, so the skin microbiome, it's like the skin has its own, right, immunological niche, and so there's a lot of interesting work on there. One of the things that's always a bit challenging is the preps that we do, and so if you check this arm versus this arm, but this one you've had a surgical prep on, does that impact it? The other thing, so I see a lot of mucosal melanoma, and in those patients we're also doing mucosal surface swabs and then looking at the tumor microbiome as well, because we talked about, right, how even though the mucosal outcomes are worse with immunotherapy compared to cutaneous, but it's why are they actually as good as they are, right? The mutation burden is so low. Why is it responding like it does? And does it have something to do with the role of the melanocytes, or does it have something to do with the gut microbiome or the tumor microbiome? Because those are kind of special areas.
Any other questions? Well, again, thanks everybody for staying throughout the day. Remember, the CME component will be emailed to you from Southern Medical Association. And again, we really appreciate our speakers who have traveled from all over the place to participate. And thanks for you guys for hanging in here for the whole day.
And
Kim?
just putting in a plug.
And also thank all our staff, David, Eleanor, Anita, et cetera, who worked really tirelessly to put this all together. So thank you guys.